Everybody. Thanks to everybody. I'm very happy to introduce this fifth European conference. This topic is moving to a better world for passion and career with eating disorder. It's a very important and difficult job. But we'll try. We'll try. Experiencing a delicate period of change, where there are a lot of issues that are rising around of us. A global mental health crisis with an increase of illness and deficit in the responses, the great financial debt that are destroying a little bit almost the welfare state. There are the problem, sometimes very heavy, about funding with the relation of poverty. Our country are inside a period of denatality, and so it's a period of decline. In our field, we are a lack of trained professionals because the university don't prepare and so don't help people to become professionals specialized in eating disorder. The problem of globalization is very important because it determines a global crisis, and we have a lot of experience, and nowadays a new period of pandemic with an increasing of epidemiological data. And now there's the war also. And afterwards, and after pandemic, the deglobalization, and so the change in the profound of our societies that increase the inequalities. And some data from APA speak also about the reduction, the global reduction of intelligence of the population. And all of this arrive in the period of climate change. So we have very enormous quantity of questions to face, and we can say that our civil society has considered it as an open-air hospital because there's an increasing suffering, an increase in systemic chaotic situation, an increase of differences between the target group of population, an increase of internal tension. In my country, we are divided as always, but more than as always. And so there's a little, very little to be optimistic. We need many things to define intervention for increasingly fluid and tiny target group. And so we have to manage research in profound in the different target group. We have to face the explosion of subjectivity, the subjectivity. That means that we have to underline the personalized care. We have to overcome also the leadership crisis. We have an hospital on open air, we said, with the very little leadership. It means that we are a little bit alone, and we have to find in ourselves the strength to face this global difficult condition. Finding unifying answers based not only on fear as it arrives along the pandemic, but basic on optimism that we need to increase cohesion. There are some threads of hope. Perhaps they help us to face the issue that I spoke above. The tension on eating disorder grows. That is important. We debate about the rebuilding system of care today also, but there are debates that arrived before from my society last year, but from Lancet that opened a series of webinars about rebuilding health system. We need to make earlier, less expensive treatments more effective, having more evidence for the specific target group, using the technologies. This is an opportunity. There is tools many times at risk, but we need of it. And so we have to imagine to use technology to arrive where otherwise we don't arrive. But we have overall to animate society, to animate territories. growing the great experience based on the expert by experience. This is the key, crucial key. Recently, we have a webinar, an assembly practically, to improve the alliance between professionals and career. It was the mighty 31 some days ago. And we open also a new line together, the academy and eating disorder career, specialized caregivers for eating disorder together. And it was very, very successful, because there are more than 260 people that will describe themselves in one day. And today we have the 5th European conference. This is very important, because the 5th European conference means that even if we was born as European chapter, not more than 4 years ago, we just organized 5. So this is the 5th conference. And so thanks to all the professionals engaged today, colleagues, friends, thanks to European chapter board, and thanks especially to ICED, that was all the time together, all the time open to the experience that we are treated today. Okay, and so I hope that today it's another important result for everybody. And now I pass the micro. I offer the micro to Janet Treasure. Janet Treasure is a very important researcher, professional trainer for many of us. She works in London, but she knows everywhere. I listened to her the first time, the comprehensive approach. It's a global approach that I love very much. She speaks today about one of the questions, the more important question, strategic question, reboot the health system for eating disorder. We need, and so we need to listen to Janet, please.
Thank you very much, Umberto. And so if you can put your screen down, and then I can put mine up, I hope.
Surely. I close immediately if I can. If I can, the other way. Okay, I close now.
Okay.
Is it?
No, it's still your screen.
Why? My screen is closed now. My screen is closed, Jeanette.
Really?
Really, my screen is closed now.
Okay. This will stop. Okay.
Try to close again, but it's just closed.
Okay.
Okay.
Good. Sorry. It's still right to it. I need to just go back somehow. Right. Okay. So now we're all ready to begin. Are you sitting comfortably, as we all say? So as I say, I hope that my talk really will follow on from Umberto's and perhaps be a little more positive, although I certainly agree that it does feel rather catastrophic, but I'm obviously in Jubilee mood.
Okay.
So I've just put these disclosures. I do have royalties for books, and I am going to show some of those. So, and I'm on some grants, but I don't think any of those would really clash with what I'm saying today. So why do we need to reboot? Well, Umberto's just given us that. And COVID-19 really has brought eating disorders to the attention of the world. Before, we were such a small, ignored area. And so it has allowed us to bring forward our concerns and celebrations about the status of eating disorder research. And we know there's been a lot of discrimination and stigma, but we can fight that with the power of collaboration. And that very much means joining up with people with lived experience, as Umberto was saying. And so I'm going to talk about that and how that's led to new interventions for comorbidity, diabetes and autistic spectrum, new targets for anorexia and binge spectrum. So you all know that with the COVID tsunami, eating disorders really hit the headlines. And of course, it posed a very interesting opportunity. It was a natural experiment, which was demonstrating to everyone the importance of environmental influences on the incidence of eating disorders. And this is, I mean, papers have come out worldwide, and this is just one example. And it's a large example from electronic database of over 5 million people, mainly from the States, but some from the UK and other countries too. And sort of nicely showing how the number of new cases, the incidence was showing a slight increase from 217 to 19. But we're seeing this very large increase in 2020, mainly females, mainly young, and mainly with anorexia nervosa, and quite severe cases, not only with ordinary eating disorder symptoms, but suicidality as well. So this gave a lot of people, and the press anyway, time to think about eating disorders and thinking a reboot. And several editorials about eating disorders were commissioned and published in very high profile journals. I'm not going to detail these because you can look at them yourself, but they're excellent. And so this provided an opportunity to reveal and overcome some of the discrimination and stigma about eating disorders that have been present. And some of the evidence of discrimination was published recently in the British Journal of Psychiatry, showing how over time eating disorders are rated as less severe and self-inflicted and under the individual's control. But luckily this, in the decade that was followed, there was a slight reduction in this. But this is a general stereotype that the public hold. In the UK, and I'm going to have, I apologise beforehand, when things are policy, I will focus more on the UK. But we haven't had any national surveys in which on mental health, which are done regularly, which have included eating disorders, although the next one, I understand, is going to have them in. And we know that weight stigma is such a pervasive aspect of society, and particularly in the medical community. And indeed, we may even ration our services based on BMI too. And the BEAT worked very hard to produce this report, which was shared with our Parliament, about research funding in eating disorders. And what they noted, that eating disorders are 9% of the mental health problem, but only have 1% of the mental health research. And a similar discrimination about research into eating disorders are there in Australia and America too. So this is a worldwide problem, probably. And also, perhaps because of the less money invested, there's been less dissemination into the top 5 psychiatry journals. A recent study showed that only 0.7% had the topic of eating disorders, whereas schizophrenia is 20%, neurodevelopmental disorders, for example, 8%. So very much we are not seen as part of the research and general mental health community. Perhaps we need to reboot by considering the changing clinical profile. I mean, our area is having major changes over these last 40 years since I've been involved in it. And the press really rather like making up all these alphabet soup of titles for us. And some of them are rather fanciful, but others probably are either subtypes or new types of disorder that we really need to consider. So the bigorexia and the reverse anorexia probably are a male phenotype of an eating disorder, but the diabulimia or type 1 diabetes with eating disorder, as most people are now preferring to call it, probably will appear as a separate disorder. So we've got a lot of change and a lot of rethinking to do. And of course, we need to reboot services and our funding by considering the changing epidemiology, which follows some of the changing diagnosis. And we're very lucky that this study came out because it updated the epidemiology as much as we know it. As I say, because binge eating disorders has only just been accepted into the ICD 11 and is reasonably recent, we haven't got many epidemiological surveys. But what you can see from this, the turquoise is the binge eating disorders and other OFSED as well, and how they make up the greater part of the epidemiology. So by not including these in surveys, often we are shortchanged and not given money and resources to have our services. And this study noted that the total eating disorder, DALI, was equivalent or even bigger than for bipolar disorder, autism spectrum, and conduct disorder. So although there haven't been national surveys, this is a survey in my neck of the woods, well, very near the Maudsley, let's say, a well-designed community study, a two-stage with a initial screening and then a second follow-up of people who scored positively. And what you can see on this is that well, I hope you can see, you might not be able to see the bottom line, but no cases of anorexia nervosa were picked up. That's not surprising. Anorexia does tend not to be picked up on screening. When I started in the field, there were a lot of studies on this, and they all found the same thing, that people could make a spot diagnosis in a school and say, we've got 10 cases, but they wouldn't show up on the screening instruments. And what you perhaps are missing, I'm missing anyway, in the bottom line, is that only 20% have gone for treatment. So this is a prevalence study, because the majority don't go for treatment. But 10% of this population in Southeast London were found to have eating disorder behaviours. And what's interesting about this is that it doesn't fit the usual stereotype. So there was an increase in Black and particularly Asian minorities. There was an increase prevalence in all shapes and sizes. So people underweight, people overweight, and people who are classified as obese too. There was still the expected increase in females too. But this reboot is very important because we have had to break a lot of the myths about what an eating disorder is in the community. And so many people do carry in their heads the stereotype of it being white, female, high socioeconomic status. And the Academy have been very active in destroying this myth by stating that eating disorders affect people of all genders, ages, races, ethnicities, body shapes and sizes, sexual orientations, and socio-economic status. So there have been, luckily, these epidemiological studies that have shown all of this. So can we reboot with lessons made from COVID? As I say, this has been a rather natural experiment because we've seen something happen which has increased the incidence and prevalence of eating disorders. And what can we learn from this? What has it taught us? Well, when we look to lived experience, the experts, it's perhaps not surprising because isolation has been noted to be a key factor in an eating disorder. And so I've got these two quotes from people with lived experience. The first one I want to highlight is from somebody who had anorexia when she was 12 and 13, and then trained to be a psychiatrist, and wrote her story up as a personal journey for the British Medical Journal. And this was a statement she had in that. I was asked to sum up my experience of anorexia in one word, in one sentence, but I can do it in one word: isolation. And another quote from another patient: it's the loneliness that will get you, not the hunger, the worrying, or the rituals, or paranoia, not the fear of getting fat. It's the loneliness that's the real killer. The longer you're ill, the worse it is. And so we know that there was a lot of isolation. That was part and parcel of what we all faced. But of course, there were other potential risk factors for this increase post-COVID. There was the increase in screen time and access to influencers that we know can, in the media, have a toxic effect in terms of eating disorders. There was a lot of weight stigma with blame and shame. There was the quote of the quarantine 15, you know, the 15 pounds increase that people were terrified into thinking that they would happen to them. And there was weight stigma, you know, patients with obesity were said to do worse in intensive care units, etc. And there was quite a lot of concern about diet and obesity and everything. And of course, there was a lot of general anxiety around. So what we saw was this rather perfect storm of social risk factors. Probably we didn't really learn that much because we had ascertained these risk factors before. The knowledge that uncertainty and anxiety is a risk factor, weight stigma, fat talk, exposure to influences in the social media, isolation and family stress. But it certainly validates these as targets of prevention and early intervention, and that probably to show how it can be worsened, but hopefully it can be remediated if we can disseminate some of the very good early intervention prevention programs we already have. So let's move on from these negative thoughts of discrimination and concerns that we have and look on the bright side. And here are pictures of 5 lovely ladies. And I do think that that's one thing that we have in our field is a secret weapon, is that we can work very well cooperatively and with support with people with lived experience. These are all examples, well, the first 4 examples of carers, and I've got somebody with lived experience herself, but there are many more, and some in the audience already, who cooperate with us so well. So it's very nice hearing Umberto talk about increasing this factor. And some facets of psychiatry don't have such a good relationship, and so it's fantastic that we do. And so these collaborations have gone on for a long time. I've been lucky to be working with people with lived experience for most of the time I've been dealing with eating disorders, and they're very eager to cooperate in terms of service and research design, and to contribute indirectly and directly for delivering new services. For example, carers provided funding for many genetic initiatives. So it was carers' money, the Price Foundation and Charlotte's Helix, that enabled us to start big collections and put us in the big boys of genetic research. And Cindy's going to be talking about this later, but that was a wonderful kickstart to research that we only had through that experience. And lived experience have been contributing in many ways, but more formally, I'm going to be talking about evidence-based co-design for the new comorbidity with diabetes. And I've been working for a long time with people with lived experience, both carers and patients, to deliver treatments for carers, for patients, and delivering and guiding self-support. So there's been a lot of work in this way over time, and we know it works well. And recently we've had sort of headlines again, but showing that eating disorders aren't to be just locked away in a cupboard as though we felt they were at one time. So my colleague Paul Robinson and Dasha have updated the medical emergencies in eating disorders, and this was published by the Royal College of Psychiatrists. I can see Agnes's picture here. She's part of the team involved in this, and so as our president was able to say, the landing page has been seen twice as many times as any other report that the college had. So we've really broken into our own college at last. Thanks a lot to you, Agnes, I think, and your hard work. So this is Charlotte, who unfortunately died, but as I say, Cindy will be telling us about the work that she really had a mission for us to work on in terms of the research agenda. I had help as well from a lady called Nina Jackson. She was cycling all over the world to raise money and was very interested in brain research. So that was able to allow us to start that at the Maudsley Hospital. And so, although I'm not doing as much on that, I remain very interested in this. And I do think that patients and carers are often very interested in this too. So I'm just going to give an example of a recent study that's come to mind that I think is quite interesting. So this was a study from Germany, from Dresden, and they're very involved in the Enigma consortium, where they work together with a large number of people sharing scans, which is very nice. And they've published this recent study looking at cortical structure, but also with a very fancy technology, histology. But don't ask me to explain it. But I can give you the bottom line, which is what they found in these are acute early onset adolescent cases, and the cortical size was reduced by 6%. And so to put it in the context of other disorders, we have 12% reduction in dementia, schizophrenia only 2%. So again, so we've got quite a significant problem here compared to other psychiatric disorders. What they're able to show with this new technique was which cells were involved, and it was mainly cells in connecting nodes, and these cells, get connections all over the brain going, and have quite high metabolic demands. So it's not surprising, because we know that the brain needs 500 calories. What you can see with the figure to the right, it just shows all the areas of the brain, and you can see that most areas of the brain are well below the norms. There's just the entorhinal cortex and the temporal pole that seem to keep their cell number. But the good news was in these adolescents was that there was a rapid reversal of these changes with weight gain. So early intervention, effective treatment can stop this. But there are questions that we need to ask about this, because it's probably a key, very important as a maintaining factor. Because these changes in the brain and this inability to be able to see connections and see the bigger picture might be stopping therapy being so helpful. And we know that social cognition is a key trait in us in humans. And so this will be particularly hit, and we see that when we measure social cognition traits. So we see, and these can cause some of the problems in communication that can arise within families, within therapists and patients. And it also has implications upon capacity to make difficult decisions about treatment, and whether people, supporters should be involved past the age of 18 or 16, because these brain changes are present for a long time and people probably need other people to help them make such decisions. So what about rebooting by co-designing and co-delivering services, and you working with people with lived experience to do this? And this is a particular area I've been interested in because of realizing that the problems that occurred in our inpatient units were very similar to the problems that occurred at home. And the way we learned to manage these difficulties could be shared with patients, with carers too, and improve some of the communication. And it's really pleasing that this work and this need to involve supporters over the lifespan, because, well, in Britain and many other services, the model was not to include family members in adults, but luckily we've got policy documents from the Academy, from BEAT and MEAD, this new emergency document, endorses the need to constantly involve supporters with for people with lived experience. And so there's so many books that I've written with patients and carers, but of course these are conflict of interest. But it is pleasing that there are other services and treatments over the world, such as the temperament-based therapy, which again endorses shared working with people, with supporters. I'm now going to move on to thinking about co-designing and co-delivering services with diabetes and with autistic spectrum disorders. So this is just one example of using a participatory approach, a formalized participatory approach called evidence-based co-design, where you work with you see we had people with type 1 diabetes, about 33 years old. We had healthcare professionals, 25, coming together on regular intervals for 6 workshops to collaboratively and iterative develop a new intervention following this design. And this was very successful because it was possible to develop a tailored toolkit with workshop themes that hadn't been considered before, when people were trying to bolt on eating disorder treatment to what's standard in diabetic care. And the themes were insulin titration, hyperglycemia, coming to terms with diabetes, fear of weight gain, revising the toolkit, and the practical elements. And this is a new intervention designed to be disseminated by diabetes specialist nurses rather than be devolved to eating disorder clinic, because they're the resource that is going to be there for life. With the diabetes, a lifetime disorder, hopefully the eating disorder can be treated and go over time. And then my colleague, Kate Chanchuria, has been particularly interested in this comorbidity with autism spectrum disorder. There's a lot of controversy and uncertainty about how much there is an overlap, and the figures that come in systematic reviews show a big range, you see, 4 to 52%. Maybe the stage of illness accounts for this. I mean, a study we did in adolescents, we only found 5% in our adolescent population, whereas if we're looking at adults, severe enduring, we get levels of about 20%. A recent study by Kendall looking at family genetics did find an increase in autistic spectrum disorders in the families of people with eating disorders from a Danish cohort. And what Kate has been specifically interested in is whether we need to design different care pathways, particularly on our inpatient units, which often people are forced to live in all the time, and that the environment might not be suitable. So things like thinking about sensory specificities, to perhaps change the decor of the ward. We've had change the food choices that are allowed, and perhaps have choices of not having to always have group therapy, which can be so common on inpatient units. So she's been able to develop a pathway called the Peace Pathway, and has written about it. What about targeting comorbidity with treatment-resistant depression? This is something in our severe enduring cases we see in up to 80% really, and is a major problem. And luckily there are new developments in psychiatry in this treatment-resistant depression, so we need to be aware of what's happening. And I'm just going to give you a little bit of data from my colleague Ulrike Schmidt, who has done TMS, transmagnetic stimulation, a treatment for resistant depression. And they did a sham controlled double-blind feasibility study of 20 sessions, where this was added to usual treatment in these severe enduring cases. And they measured outcomes over 4 months, and after they measured even longer, but after that people could choose to have TMS if they didn't get it. And they looked at neural and cognitive predictors of treatment. And as I say, the sham completers were offered the real after 4 months, followed up over time. And what you can see, I hope you can see, but I'm not seeing it very clearly, but there wasn't much difference in BMI at 4 months. There wasn't much difference in EDQ, but there was a difference in depression. So the TMS did reduce depression at 4 months, which is interesting, but nice to know that this treatment is effective. When the follow-up later on, which is a bit complicated because some people had dropped out and some people had the sham group had the active treatment, but there was a little bit, a suggestion that BMI might have been improved in the group with TMS. There was less of a difference in depression. So that's an example that perhaps we can use these other treatments that are available, and we know that the field of psychiatry is undergoing a great change with psychedelics, ketamine, psilocybin, etc., being used in depression, trauma, OCD, etc. So and studies are in progress in eating disorders. So it's a question of watching this space. What about rebooting with other new targets and skills? Well, we know that at the heart of anorexia is this big lump of fear, which may be specific to food, but it might be people, others, or life in general. And here we are with the anorexia just propping away that fear, so the individual feels safe, but at the same time is trapped. And have we done enough to focus on those fears? I would say no. And so I've been interested to look at the new developments as they're only just occurring in exposure treatments to inhibit fear learning. So people are now more interested in looking at trauma memories associated with food, or the potential for rejection due to weight stigma after changing their diet. And so new forms of exposure-like treatments are being studied, and so we're waiting to get these results. But Cherry Levinson has done very impressive work with imaginal exposure, where people just write about imagining what would happen if they carry on eating and gaining weight, and what would be the consequences, and managing to change their expectancies of being alienated from everybody and shunned, etc., to one of hopefully acceptance. And so she did a nice feasibility study, and a new study is in progress. So that's something to look forward to. My colleague Valentina Cardi has worked with us here. We've been looking to see if we can modify avatar treatment. That's where you learn to talk back to your anorexic voice, as people do in psychosis, and whether that can encourage increased change in fear. Another avenue that my colleague has been starting is thinking of other virtual reality paradigms. So having a kitchen where people are encouraged to touch food, plan putting food on a plate. And this builds on the work we've done before, where we, had people lifting virtual food to their mouths and found that it produced fears, etc. In this one that Valentina's doing, we're exploring whether some of the paradigms that we found outside virtual reality, such as music support, or support of somebody with lived experience. So she's doing an avatar giving support, and a pet to give a pink elephant to give a positive companion. And then there's fantastic work going on in Barcelona and Valencia with virtual reality that they've done in terms of binge eating disorder. They're now doing it with body exposure for anorexia as well. And so very exciting work. This just shows the example that they do, sort of exposing people to them becoming larger. And they had 5 of these virtual reality exposure therapy sessions and got improvements in the fear of gaining weight, and which lasted at follow-up. Also, there's been interest in targeting some of the unhelpful habits that arise in binge spectrum disorders. And there's been a lot of interest in trying to understand the neurobiology that underpins binge eating disorder. So there's the idea of stress and emotional eating and upset triggering this problem. There's interested in cognitive features, whether there's tends to be sort of a rigidity and all or non factors. Worrying about certain types of food, such as high levels of sugar and artificial flavorings, etc., leading on to the food addiction thought. And I'm just going to present some work we've done with the University of Exeter, who had developed this very simple little app, which was designed to train inhibitory control over eating. And you can see it can be on your phone or on an iPad, and you can program it to have what you want to stop eating, and perhaps foods you like to eat. And very simple, green is go and you have to touch those, but you have to not touch when it's red, and that's how it works. And this has gone through several iterations, being improved by feedback all the time in different populations. So it started in non-clinical populations, and they did find in the ordinary population who are a bit interested to try it and feeling a little bit overweight, that it did reduce their intake and reduce body fat and weight. We worked with the Exeter group looking at clinical populations, and we surprisingly really found that we did get changes in eating disorder psychopathology, and people saying they didn't like the binge foods that they were avoiding. We didn't manage to reduce the number of binges, but we feel that this is a sort of step on the pathway for such a simple 5 minutes a night or a week, depending on how enthusiastic people were in doing it. So, coming to conclusions, I hope that I have perhaps given a little bit of optimism for our field, and feel that perhaps we can have a fresh start and reboot ourselves amongst our colleagues in the rest of the medical world. And there's a little thing that COVID-19 has brought eating disorders to the attention of the world. And this can perhaps help us to move on from the discrimination and stigma which has been associated with eating disorders. And that has only been ameliorated by the wonderful collaboration that we have had over time with people with lived experience. And I do want to acknowledge that. I think we're ahead of the game in many areas of psychiatry with this. And so this has led to new interventions for those with comorbidity, for instance, for those with diabetes, autism spectrum, those perhaps with treatment-resistant depression. And it's perhaps getting us to focus on some of the core targets now that we have to tackle, this fear and disgust and alienation that are central to eating disorders, and some ability to be able to break these bad circuits that are there. So thank you very much indeed for listening to this, and I hope you can share a bit of my optimism. Thank you.
Yeah, thanks a lot, Jeanette. I'm always optimist, but we have to go to look at the reality. This is the reason because I put the list before. I thank very much your intervention because it enlarged our knowledge and it opens new hope, because we need more research, more inclusion, more collaboration with the other field inside the mental health and the medical area together for overall the people with comorbidity. We have sometimes, there are some questions that somebody want to pose to Professor Treasure. Normally we can say that when everybody stay silent, it means they are satisfied. They are
Oh,
very
good.
satisfied. They are very satisfied. Okay. And so we pass now, we go on with the Orly Iona Drori. I hope to pronounce well. She's from the nutrition field, clinical dietitian. She works in Israel at the Lev Asharon Mental Health Center, and she teaches in the University for the School of Social Work. The title is Negative and Positive Affect as Mediator between early childhood parents' empathy and intrusiveness and the addiction in women. Thanks to you, Orly. It's your time.
Hi. Hi, I'm very excited to be here and to present my presentation. I just share my screen. I hope I can do it. If you excuse me for a second, I just open it. Okay. So I'll try again. Okay, so you can all see, right? Yeah? You can see my presentation, yes?
Yes.
Okay. So hi everyone. So my name is Orly Drori. I'm a clinical dietitian for about 30 years now and a clinical social worker and a PhD student in the University of Bar-Ilan in Israel. And I can say before I start my presentation is that I am myself deal most of my life with binge eating. And I think definitely I am a food addict, but I'm in recovery for many years now. So, so if you can look at my history. So when I went to study nutrition, it's because I wanted to help myself control the food that I couldn't control. And then for many years, I was a dietitian and I basically succeeded in controlling myself, but not always. And I had binge episodes throughout all my life. And then I decided I need to find another way. And then I went to study psychology and I went on to social work. And this is what I do now. So definitely it comes from somewhere very much from within me, this whole research. And this is what I do in my PhD. I work with women and men who deals with binge eating disorder. And this is what I'm going to talk about today. So I'll talk about the binge eating disorder, but specifically the addiction component of this disorder. And I will present a part of my research. So binge eating. So we know this is a behavioral disorder in which a person consumes a large amount of food in short time. And this episode can happen a few times a week and sometimes a few times a day. And we know it's accompanied by negative emotions and of course gaining weight. So when we think about a binge eater or someone who is overweight, the first thing that comes to our mind that he is overweight or she, and we need to help them lose the weight because it's unhealthy, it doesn't look good. And this is basically their motivation to come to treatment. Most people that I see in my clinic for years now, they just want to get the weight off. So the common intervention will be dietary modification. We'll try to put them on a diet. And then also we add sometimes CBT to the program in order to help them modify beliefs and thoughts. But I want to talk about the addiction component. And basically when we talk about addiction, we don't talk only behavior and cognition, we talk about the self and the things that drive people to be engaged in addiction. Why do we need this addiction? And we do know that food addiction for more than a decade is known to be an addiction like any other. Of course, we don't talk about dopamine, induced dopamine, but we do talk about dopamine as being the major player in this addiction, just like any others. So we're basically addicted to dopamine. And the Yellow Food Addiction is the scale that examines the amount of symptoms to addiction, which I will elaborate further on in my presentation. So first of all, when I try to find with me what can help me stop eating or stop planning this food ceremonies, I couldn't find. I didn't know where to look. It was just like I tried to set up goals for how to eat and what not to eat. And I was a dietitian, so it might be easier, but it wasn't. And then I went and I studied and I learned something about the self, which opened up so much, or so much pain also, but so much knowledge. And then throughout my searches of trying to find how to make a person get a grip on himself and not go through with this binge, the whole binge, even stop in the middle, I come across the escape theory of Hitton and Baumeister from 1991, which I really recommend, and I'm sure most of you know it. So what they talk about is the binge eating as escape from self-awareness. What they basically say is that individuals who are have high expectations of themselves and they don't live up to them and they fail to achieve their goals, they feel terrible pain, something they cannot bear, and they want to escape from awareness. So what they do is they narrow their awareness to that small bite, a lot of bites. When we talk about a binge, it's a long bite, but this is how we narrow our awareness and we don't feel the pain and we don't feel all the negative emotions that we meet when we fail to set our goals. And so a few years ago, Higgins and his associates, they tested the escape theory of binge eating among Latinas women. And I'll show you the model because what I did is replication for this research. So they tested the escape theory through 3 clusters: the family, personality, and environment. And they wanted to see, first of all, they wanted to see if there will be correlation to binge eating, whereas they measured the frequency of the episode of binge eating. And they wanted to see for each and every variable if the negative emotion will mediate the correlation. Of course, they did found a correlation. And my research, my whole research of my PhD is addiction to binge eating among women, and of course the escape theory and emotion. So what I did also, I used 3 clusters to examine first the family, personality, and environmental. But on this presentation, I'm going to present only one part of the family, is the early childhood relationship with the mother, not with the father. I'm not going to show the father right now. And but I did the same way. I wanted to see if negative emotion will mediate the correlation between these variables, but not to the amount of binge episode, but to the addiction to binge eating. And I also added an examination of positive emotion to see if they will if I'll find correlation and mediation. So I'm going to present right now is the research that basically talk about the early relationship with the mother and the correlation to the addiction to the binge eating, and using emotions, the negative and the positive. And I did this research, of course, with my colleague, Shirley Ben Shlomo. She's a doctor from University of Bar Ilan in Israel. So what stands behind all my research is Winnicott's words, basically. He said the inherited potential of an infant cannot become an infant unless it's linked to maternal care. So Winnicott and other object theory said that what makes our personality, it basically integration between our inner world and the environment. And we know that when a baby is born, the most important environment is the parent and of course the mother. So what I wanted to see the early relationship with the mother, when I tested empathy or lack of empathy in early childhood and intrusiveness in early childhood of the mother with the child, how it will correlate with the addiction to binge eating today when the woman is a grown-up. And I wanted to see if, oh, I'm sorry, they're too positive, but one of them is supposed to be a negative emotion and a positive emotion, if they will mediate these correlations. And so this part of my research has two questions. As I said, with the negative and positive emotion mediate the correlation between early childhood empathy and intrusiveness and the binge eating addiction. And some information about the participants. So there were 890 women. They were all matured, 71 in relationship. Basically, if you can look at the data, you see a very functional women. And this is also the type of women that I work with in my clinic, women who are very much functioning in every way. They are career women, they have academic education high, most of them. They work full-time, half-time, they have children, they have husbands or spouse, and they lead a really full life. And yet, all the people in my sample, all the women, are overweight. As you can see, the BMI was 33.6. It means that we had almost 60, BMI 60, a few women. Most of them were obese. And most of them did not work out. And most of them, if you can see, are always engaged, looking for ways to lose the weight in all sorts of ways. And I wrote psychological first, but it's not the first. First, they all go to dietitians and try diets, and they start support groups and surgical. Sometimes it doesn't work, and they go through surgeons, not just one, but twice or three times even, and psychological also, all trying to find a way to lose the weight and trying to find a way to stop this behavior. So a little bit about the variables. So maternal empathy is an effective and cognitive aspect of our personality, which we want to be able to give to people. We want to stand in front of people and to understand their feelings. And we also want that from other people, that we be in front of them and they will understand our feeling, not to identify with feelings, but to understand them. And there is this thing, for example, when we talk about a mom, this is really important that the mother will understand the emotions of her child. And so I give an example where we all can relate. For example, think about your little kids, and like we want them to do their homework, and it's really important to me that he will do his math, and he doesn't want to. He wants to go and play. He wants to do other things, but definitely he doesn't want to sit and do his homework. And then I get angry, and I only get listen to my fears, to my concern that he's not going to learn, he's going to be behind, maybe it's a whole chaos of my feelings, but I don't stop to ask myself or him, what's going on? Why don't you want? And I assume he just being lazy, he doesn't want to, but I don't listen to the fear that he might have, to the confusion, to bad emotions that he might feel when he's in front of his homework in math. So, and this is really a small example, but if you think about lack of empathy from a mother who always engaged with her own emotions and does not stop and listen and understand the child emotion, so we can see that lack of empathy can derive into social impairment and aggression, conduct disorder, destructive behavior disorders. We all know that from literature and from life, of course. And when we come to talk about intrusiveness, this is even worse. So when you talk about intrusiveness, is the parental interference with the child needs, interest, or behavior. It's like when the mother is so much engaged with her own values, feelings, fears, her own mind, and she's very determined, her mind in the child's mind. So the child basically lose contact with his own inner world, and it can undermine children autonomy and confidence. And Winnicott says in one of his articles that when a child has a conflict between his own inner world and the parent, in order to watch out for himself and also watch out for the parent to be his parent, he can take his inner world and just shove it in and have just forget about himself and live the parents' wants and wishes. And this is, when we talk about bad emotions, we can know that, and you can see also the study, that it linked to fear among infants, negative child outcome, regulatory and social emotional problem. So negative emotion can derive from lack of empathy and intrusiveness. We talk about anger, guilt, fear, nervousness, and we talk about feelings that we carry throughout life when we under this kind of parenthood, and we know that negative emotions are a major player in the onset of BD. Positive emotion, of course, enthusiasm, vigorous, happiness, good feeling, high energy. We know that low level of these emotions can also play an effect on the onset of BD. And come to the addiction. So as I said before, we know food addiction exists, and we know that it has the same pattern of other addictions. And the YAL food addiction is the scale that I use, but many researchers use to diagnose the addiction. And it does diagnose by counting the symptoms of addiction. And these symptoms are related, and what they do is modified from other addiction to the eating disorder behavior. And we classified food addict as mild. As you can see, the number of symptoms, as higher as they get, of course, is more severe addiction. So the results. So you can see there was, I did found a correlation between early childhood maternal empathy or lack of empathy to the addiction of binge eating. And you can see also that negative emotion did mediate this correlation. And the meaning of emotion to be able to mediate this correlation is that early childhood maternal empathy or lack of empathy or intrusiveness or whatever happened in childhood leaves this woman with bad emotions. But if we can see emotions is something we can work with. We cannot always work with what happened in the past, but we can work if we understand the correlation of these variables. We can work with changing the negative emotion and maybe do some relief and see more or less addiction to binge eating. And so we can see also from positive end that more empathy would cause more positive emotions and less addiction. And of course, Winnicott says, in her empathic focus on the child needs, the devoted mother treat the child as he or she has a self that is substantive and worthy of notice. And this is important because the mother has a very important role in developing a very strong ego and I am, a good self that can carry out good emotions throughout life. And when we have lack of empathy, these might be something that will not prevail. And also we can see, of course, the intrusiveness. Also, we found correlation to the addiction. It means that more intrusiveness in early childhood lead to more addiction, and it does also go through this route of mediation, and more intrusiveness cause more negative emotion. So the intrusiveness was not once, but throughout the child's life. But when we see them as adults, we can see the reaction and the correlation to the addiction, binge eating. And also positive emotion, we see, again, not a very high correlation, but still substantial. And we see more intrusiveness, less most positive emotion in a grown-up age, and more addiction. So also when we talk about intrusiveness and bad emotion, so we can understand the root of needing to find an escape from emotion that starts somewhere during childhood and keep on growing without working with that throughout life. It comes down to a person who is a grown-up, as a woman, and when she carries these emotions with her, and then she come out to the world and she finds herself struggling and find, again, like this theory says, a way that showing her that she's not up to her own standards. It's an impossible pain. And the binge eating, which is to binge eat, it means that I can eat as much as I want, as much as I want. This is like heaven for someone who actually want to escape from reality, and they just let themselves be in that place in order to find. A patient told me, I want to relax. This is a way to relax from something that really hurts within. So I come to the contribution of this study. So I say first, we know negative emotions are involved and can be a cause for wanting to escape reality. But I want to find out what stands behind these emotions, trying to go back to where it all starts and make this a conversation that we can talk about the early childhood relation with the mother and the father, and other variables that we can go and teach the public, and we can tell mothers, pay attention to what happens today because it doesn't go away. And also in therapy, we can work with these women, not just on their behaviors or their thoughts, or trying to analyze situation where you eat and you want to eat less, but also go back to relationship in the past, to family factors can be a factor also in this day and age, because the pain does not go away. And as this study, it's to go and find a source that makes women binge eat and try to escape from reality. Thank you. And if you have questions, thank you so much.
Thank you so much, Orly, Yona. Thank you so much. I hope very much your presentation, because from the starting you speak about your history. It is always helpful for us. Thanks a lot. And as the World Health Organization said, mental health is a building. It's a building starting from the basic, genetic basic, and after that, the relationship. And so we need to pay more attention, absolutely. We need to pay more attention to the context, starting from the mothers, as you said. I love very much your intervention also because you speak about addiction. I came from this field, and now I'm the guest editor of the Eating Disorder Journal in the topical collection on food and addiction. We speak about food and addiction. Okay. So if there are some questions from some attendee from US or otherwise, as I said before, when nobody asked to take words, we pass to the next speaker, my friend Ashish. Ashish is vice chair of the faculty of eating disorder in the Royal College of Psychiatrists. He is associate director and clinical lead of the unit for eating disorder in the Mercy Foundation, the Mercy Hospital. He is the immediate past president of the European chapter of eating disorder. He is the very fundamental person that organized the majority of our European conference. Thanks, Ashish.
Thank you, Umberto. Can you see my slides, by the way?
Yeah, it appears.
Thank you. I could not hear you, Liz.
Can you open it up as a slideshow, the word slideshow at the top? If you click on that, then you'll see the whole screen rather than what we can see now is all of the slides simultaneously.
Oh, I see. Okay.
You are waiting for the video presentation?
Yeah, I'm just trying to.
Starting from the video.
That's okay.
Can you see it, or can you see the change?
It's still the same, but it's okay because you can see your slides clearly.
Liz, I can't hear you. I'm sorry. Can you see my slides, or you
Yes,
cannot?
I'm seeing your slide now.
And can you see the change of slides as well?
The change of slides, yes. This is the disclosure. Huh? It appears that
Yeah,
it's
okay.
disclosure.
Thank you.
This is the first.
So thank you,
slide.
Umberto, and thank you everyone for joining in today. And in today's presentation, I'm going to talk about parents' experience of caring for their children with anorexia nervosa and what can help the family. It is quite significant but very old matter. And Umberto has said that I work as a clinician with young people and their parents in my service, which looks after quite a number of patients between Liverpool and Manchester. So we cover quite a big geographical area and a population of 650,000 people, and we receive approximately 300 referrals to our service in a year, and many of them are very complex and very unwell, and hence we have to think about how we could help them in the best possible manner. So we try to look for the ways by which we could find some solution to the patients. So one of the thinking, so this is my disclosure. I've received some grants for research, and more recently got a grant from our commissioners in the NHS, and currently I'm working on a PhD with Professor Janet Treasure, who is my guru, and these are acknowledgements to Professor Janet Treasure and Dr. Hubertus Himmerich, who are my supervisors at King's College London, and I've learned quite a lot and continue to learn from them without doubt. So coming back to the topic, that families are extremely important and for any illness, but in the context of anorexia nervosa or eating disorder, it becomes even more important. And so during this talk, I will be focusing on importance of families in management of eating disorders, parents' experience of caring, and I will share some experience from systematic review, which I am undertaking at the moment. And I will look at some of the scope for new intervention, which might be helpful. So we all know that there are biological, psychological, and social model of causation of eating disorders, and lots of research has happened. When you look at the research data, and there is one of the significant development which happened, and lots of colleagues have done the research in this field, and there are some significant papers. So there is one of the models or theories of socio-cultural theory of eating disorders. And the research data indicates that the mothers with eating disorder are more likely to have infants with feeding difficulties, to restrict their child eating in early and middle childhood, to use food for non-nutritive purposes, for example, to reward their children, to distract them from doing or not doing some other behavioral aspect of their life. And this is in comparison to what compared to mothers without an eating disorder history. So there is some difference between mothers with eating disorder and mothers without eating disorders and how they treat their children. And this is in research, and I've given the reference on the slide itself. So socio-cultural theory of eating disorders indicates that, and this is with evidence, that daughters of mothers with eating disorders are more likely to be affected with eating disorder behavior compared to boys. And a study of 222 children and their parents, which included 166 mothers, and then it was analyzed by using linear mixed model analysis, identified significant main effects of maternal group, which compare between eating disorder versus psychiatric control versus general control on the age at which solids were introduced by these mothers to their children. So there was a difference there. Significantly higher level of eating disorder psychopathology were found in mothers who had eating disorders. And final multivariate models, maternal education and maternal concern about child weight were significant in predicting general eating disorder psychopathology. So just to simplify this, that if moms were more, or mothers were highly educated, their chances of being concerned about their weight were more significant or more common. Maternal concern about child's weight was significant in predicting dietary restraint. So if a mother was showing high level of concern about child's weight, they were more likely to restrict their children from eating or not eating certain types of food, or quantity of food for that matter. Family exposure to stressful life events was significant in predicting emotional eating. Children's family satisfaction scores were significant in predicting loss of control eating. And however, results did not differ significantly across boys and girls. So the outcome were similar for boys and girls. So this model also included tripartite influence model and model of sociocultural influences. So there was three main areas of influence, which were family, peers, and media, and important predecessors in development of eating disorder pathology. So they were identified. Of course, in later studies, the significance was not as high as in some of the studies which were carried out earlier. These three influences affect body dissatisfaction by two processes. One is the internalization of unrealistic appearance standards. So the thin ideal, so people think that if they're thin, that is the ideal for them, and increase appearance comparison. So patients or persons who had these difficulties, they were dissatisfied, and through two processes about their body or appearance. So they were comparing themselves all the time to be thin, and this was thin ideal, and they were comparing themselves with others, and hence there was a comparison there. So these mediating variables led to body dissatisfaction, and this is the underlying principles of psychopathology of eating disorders in many of the cases, which in turn influences onset and maintenance of disordered eating symptoms, as I said earlier. So parenting behavior and eating disorder pathology, let's think about that. Eating disorder patients report that their parents displayed significant lower levels of care and increased level of overprotection, according to one of the studies. More critical comments about weight and shape was made by the parents who were overprotective. Bulimia nervosa patients indicated that influenced by a history of dieting, childhood obesity, abusive relationship, including abusive parenting, and high expectations, low contact, and critical comments about weight and shape by family members and modeling, teasing and bullying from peers. These were indicated by the bulimia nervosa patients in one of the significant studies. Eating conflicts, struggling around meals and unpleasant meals in childhood, parental overprotection and high concerns, as well as parental critical comments about appearance and eating were related to a subsequent anorexia nervosa diagnosis, according to another study. This slide is quite important because it was quite a large study. It was part of a large European multi-center project, and it was conducted over in quite a few countries, including UK, Spain, Italy, and Slovenia. So it was spread over 4 countries. It was quite a large study in which 653 eating disorder patients and 611 controls participated. So in anorexia nervosa restrictive type, there was significant high level of prediction of body dissatisfaction, and there was a high significance level. And there was significant prediction of mothers being critical, and there was high level of perceived influence from the family and the media. And it also indicated that mother's educational level was high. In anorexia nervosa binge purging type, there was significantly high level of prediction of body dissatisfaction and mother being critical and perceived influences from the family and the media and peers. And they were also predicted by educational level. Bulimia nervosa was also significantly predicted by body dissatisfaction, mothers being critical, and mother's age, and perceived influences from the family and the media and the peers. However, in ADNOS, there was also significantly predicted by body dissatisfaction, mothers being critical, perceived influences from the family and the media, and also predicted by educational level. So in all these types of eating disorder, there are significant finding there. That because there was presence of body dissatisfactions, mother being critical, influenced by family and media. They were a common theme across these all diagnostic types. The 3 tripartite, family, peer, and media influence variables are directly and indirectly through body dissatisfaction related to eating disorder symptomatology, according to one of the significant studies. Perceived influences from the family has been shown to foster body dissatisfaction and eating pathology through one or more of the following influences. So there has been important findings there, which indicates that there is general negative attitude towards weight and shape, teasing or negative oral commentary, encouragement to diet, parental weight loss practices, or not modeling of weight concerns. So these are important findings there. Perceived influences of media have also commonly been found to lead directly to disordered eating symptoms and indirectly through body dissatisfaction. So what are the results and what do they tell us? The results from the separate ED models reveal that a direct relationship was observed for the perceived influences from the family and the media for eating disorder not otherwise specified or ADNOS and healthy controls. Verbally abusive parenting styles were more pertinent both directly and indirectly through family influences in the bulimic, which included anorexia nervosa binge purging type and pure bulimia nervosa eating disorder subtypes. The findings from individual socio-family models says that interventions aimed at reducing abusive parenting styles may be more beneficial in preventing eating disorder characterized by mainly bulimic symptomatology. A focus on family and media influences may be more broadly relevant in prevention for body dissatisfaction in ADNOS and controls. So these were the key findings from this study by Krug and et al., which was a big study across 4 countries. So how we could link the socio-family model with carers' experience of caring, how it links up. Because we know that expressed emotions such as criticism, hostility, warmth, emotional involvement of carer towards an ill person is quite important and plays some part, not everything, but important part in development and maintenance of eating disorder. We know from our clinical experiences and research experiences. Critical comments and criticism and emotional over-involvement, EOI, were identified as important factors in development of child psychopathology. High expressed emotion may represent a maladaptive response to an illness and may contribute to an exacerbation of psychiatric symptoms. Up to 47% of caregivers showed high expressed emotion. Lower caregiver skills, higher anorexia nervosa symptoms, impact, higher level of depression and motivation to change in caregivers were significant predictors for high expressed emotion. So these are the theme, and we'll look at finding from some of the studies that how expressed emotions influences the outcome of interventions and how it causes higher distress, higher depression, and lack of skills among parents, and causes worse prognosis or outcome for patients who suffer from eating disorders. So a study by Hind et al. In 2016, in a study of 144 patients with anorexia and 196 carers, about 1/3 of carers had moderate to severe level of psychological distress, which included depression, anxiety, and stress. The level of distress was significantly lower in fathers compared to mothers, and level of accommodating behavior in fathers was lower than seen in mothers. So how we could correlate it? So mothers' time spent caregiving was significantly correlated with their levels of accommodating behavior. So basically what this research was saying is that if mothers spend more time caregiving to children with eating disorder, they will show more higher levels of accommodating behavior, meaning that, and what accommodating behavior means, that there will be causing more difficulties in terms of maintenance of eating disorder in the children. So in turn, the level of accommodating behavior was significantly correlated with expressed emotion. So mothers with higher level of expressed emotions are more likely to show accommodating behavior towards children. And hence they will be showing more carer distress. And these factors were negatively correlated with protective factors and carers' skills and social support. So what it means is that if there was lack of social support and there was lack of carers' skills in helping their young people, they were more likely to show distress. Protective factors and carers' skills and social support were significantly correlated with each other. So if parents having higher carers' skills and social support, they were more protective of either development or maintenance of eating disorder. Patient social aptitude was significantly negatively correlated with mother's level of accommodating behavior and distress. Patients' distress and severity of eating disorder and obsessive compulsive symptoms were not significantly correlated with mother's caregiving variables. So some of the outcome from this study was that mothers also showed significantly higher emotional over-involvement and overall expressed emotion than fathers. Mothers and fathers did not significantly differ in critical comments, so they were making critical comments almost equal levels. Patients perceived their mothers as more overprotective and warm compared to their fathers, which is not surprising. Patients perceived no significant differences between their two parents in critical comments, which I already said. There was another study by Lagrange et al. In 1992 and few other studies. And some of the earlier studies had shown that parental expressed emotion predicts treatment response in family therapy for adolescents with anorexia nervosa. High parental expressed emotion has been associated with treatment dropout and poor treatment outcomes. So if you're using family therapy, the chances of it succeeding is low if you parents were having or showing higher expressed emotions. These are the outcome from these earlier studies. However, in 2012, another study by Lagrange indicated that, and this study was conducted over including 121 adolescents, and this was a RCT, and it indicated that this intervention did not moderate treatment outcome, nor was it a non-specific predictor of remission. However, high baseline maternal criticism was associated with greater likelihood of treatment dropout, and high baseline paternal criticism significantly predicted less improvement in eating disorder psychopathology. Adolescents whose mothers displayed greater baseline hostility had greater increase in weight when they were received adolescent-focused therapy. So if FPD didn't work, if you tried adolescent-focused therapy, AFT, then it is more likely to work, because expressed emotions can come in the way of success of FPD. There was another study by Alan et al. In 2017, which showed that, which was conducted over 107 adolescents and their parents, and it indicated that at baseline, 44% of mothers and 26% of fathers were rated as having high expressed emotions. For mothers, 24% were high on criticism and 27% were high on emotional over-involvement. For fathers, 17% were high on criticism and 20% were high on emotional over-involvement. Significant differences for illness duration with adolescent of mothers with high criticism having a longer duration of illness prior to treatment compared with adolescent of mothers with low criticism. So this data was further analyzed, and we showed that logistic regression were undertaken to evaluate the relationship between parental expressed emotion at end of treatment, remission status, and treatment type after controlling for baseline parental expressed emotions. However, there were no significant findings for maternal emotional over-involvement or expressed emotion, not for paternal criticism, emotional over-involvement, or overall expressed emotion. However, the analysis of maternal criticism was found to be significant. In the final model, treatment type was significantly associated with end of treatment maternal criticism after controlling for baseline criticism and end of treatment remission status. So, maternal criticism was more common for adolescents with a longer duration of illness. Parental expressed emotion might be associated with severity of illness. However, no association was found with weight. This is contrary to previous study, which was conducted in 2000, which found that adolescents from high expressed emotion families had significantly lower baseline weight than those from low expressed emotion families. So outcome is this, that high expressed emotion may reflect the challenges of caring for a child with severe eating disorders. And there was another studies by Matthews in 2020, which was conducted over 46 siblings. Siblings of adolescents with anorexia nervosa are vulnerable to anxiety and parentification behaviors. Negative interpersonal interactions specific to having a brother or sister with anorexia nervosa may perpetuate risk for poor well-being. Caregivers may not be attuned to these struggles, highlighting the importance of provider and family education about sibling vulnerabilities. There are some therapeutic interventions that target siblings of adolescents with anorexia nervosa are also indicated. So this study was quite important for siblings because prior to this study, there were not many studies focusing on siblings, and it indicated higher level of sibling distress and accommodating behavior, and how mothers high level of accommodating behavior can affect not only the patient themselves, but also the siblings. Supporting families in helping them reduce less adopted behaviors such as accommodation can improve siblings' distress and prevalence or incidence of any mental disorder in them. Finally, I'm going to mention about important trial which happened in Austria. It was called ICED trial, and in this, intervention for caregivers of children and adolescents with anorexia nervosa was done, and it was based on cognitive interpersonal model of maintaining factors for eating disorder with the aim to reduce expression emotion and burden in caregivers and improve caregivers' skills. Though there were some important findings from that, it helped with dysfunctional communication, unhelpful reaction and emotions were addressed, and it helped to increase communication skills, to handle difficult behavior, and it helped with the studies to encourage autonomy in patients in order to reduce expression emotion. So they used online model as well as workshop model in this study, and they gave weekly handouts and manual to read more about the topics which were addressed, and they used DVD and case examples, and case examples of unhelpful and helpful communication was used. But unfortunately, there was no significant finding from these studies. Obviously, there is a scope of more research and intervention in this particular aspect of patient and carer relationship, and how high expression emotions and carers distress affects the not only genesis of eating disorder, but also maintenance of eating disorder in patients. So with that, I stop. Thank you.
Thanks, Ashish. Ashish, it's an interesting intervention. Explain we have to work very much more linked to the careers because we need of them. They have the opportunity to change the life of our patient, but they need from us because they are suffer from a large amount of stress. For all the caregivers for the mental illness and eating disorder too, are exposed to the stressful illness also. And so we have to train, supervise them, and so listen to them and teach to them. Thanks a lot. Thanks a lot. I remember that in the last years of the 19th century, the psychiatrist named Carlo Morselli found from the beginning, it was the inventor of the dysmorphophobia. And it was a very strange illness at this period. Nowadays, it's what inside the family, the large part of the parents talk about with their children. And so they became at risk, their children, because they are too critic about body expression. Thanks, Ashish. There are some questions, some intervention.
Yes, if there is any question, I'm happy to answer. Thank you.
I think Helen had a question.
If you have some, I don't listen well. So if there are somebody that want to pose a question, please. No, there aren't people with the question. And so we use the same phrase. When nobody pose a question, it means that they are satisfied. And now we pass, together with the president of the European chapter.
I've got a quick question.
Ah, you have a question? Okay, welcome, please. Eileen, please. I never seen the
It's only me.
Sorry,
I just bunged it up really quickly. I thought you might have seen in the comments. Ashish, I'd love to know, I understand all the implications of family distress and emotion at the time with patients. But I'd love to see some of the research that shows that the ongoing work that we're doing with carers is actually bringing emotional stability into families within this incredibly stressful time. Also, I wondered if you've got any thoughts on EFFT as a good form of treatment alongside families to talk about those emotions that you've been talking about within your presentation. Thanks so much.
Yeah, thank you, Helen. So just to mention that SUCCEED study, which I talked about, was published in 2020, and some work from that, there were actually 3-4 papers in relation to that. However, there was no significant finding which authors have accepted themselves. And this is not to say that there are no ways to help the young people or the families or the parents when they are having family distress or difficult dynamics or express emotion, as we call them. In my clinical practice, I must say, Helen, that I work very closely with our family therapist and CBT therapist, and sometimes we involve DBT therapist as well, though they are not directly part of my service. So there are ways to help these young people, and like one of the papers which I was talking about does mention that if ABT doesn't work, try AFT, for example. Similarly, when we are dealing with patients, one of the models we use is that not to do group therapy. For example, in family therapy, typically we bring young people and parents in the same room, same session. But if there is very high level of expressed emotion, we tend to work separately with them, and that helps. And when the improvement happens, we start to bring them together. So there are ways to deal with them, but and I'm sure lots of research is happening, and we will, as we go forward, we will get more outcome from those research of success or not. Generating research in therapeutic intervention has been challenged because of lack of highest level of evidence in there. But as we have moved on, we are generating lots of evidence there. Also, I must say that in my own service, and I can share the data which we have generated during COVID time in May 2020, we have started a psychoeducational group, which we brought together the parents and the children together. And this was a 5-session group by my family therapist, myself, the dietitian, and the nurse practitioner who was working on body self-image of the patients. And there was some good evidence from that intervention, which we conducted over a period of time. We collected data, and I think we presented the data from that intervention in one of the Royal College of Psychiatrists conference, May 2022 conference, I think. So there are ways to deal with or help the patients and carers. And I'm working with Professor Trazer currently to implement Triangle project in children and young people, which will be online group model or group sessions, which will be supporting parents and carers as well as young people. And we are hoping that there will be some positive outcome from that, because we'll be using handbooks, we'll be using supervised groups, and patients and carers would have opportunity to view some clinical videos and then bring out their outcomes or thoughts, and which has been found therapeutic in adults. So hopefully that will be helpful for young people and parents. Helen has question, Umberto, I think.
Exactly. Helena has another.
Yeah, I just wanted to say thank you.
She's very active.
Well, as the care representative on the board of the European chapter, I do feel like I have to sort of stand up a little bit for carers. So that's really why I'm sort of asking these questions on behalf of others who aren't here. And thank you, Ashish, for mentioning the Triangle project, which will be really useful. I think we have to. The generation of clinicians nowadays, both in Europe and across the globe, are starting to realise that carers and family members are part of the solution rather than the problem. And I think one of the things that sort of frustrates me most is when we look back at research that is quite outdated in some ways. And I think we have to be so careful how we're teaching the next generation of clinicians coming up, behind you guys who are so wonderful, and I know what your hearts are and your passions are for carers and for family members. So this is why I've sort of put a couple of things in the chat and also asked a couple of questions, Ashish. So not putting you on the spot at all, but I think we've got to be so careful with our language, because other clinicians are not as adept at understanding families as you are. And I think we really have to be careful on how we represent families in their highest distress. When you put yourself in the shoes of those family members, the emotional distress is enormous, which may not have been prior to the illness. And I think we have to look at research a little bit in as far as, should we be looking at what somebody's emotional responses were like prior to an illness like an eating disorder hitting the family. That I'll stop talking now. My rant is over.
No, Helen, the questions you have raised are extremely important, and in some way you have been involved in Triangle in some form or shape. We met, I think, and going forward there is opportunity to meet again and take it from there. But in our team, we involve patient and carers all the time, not only service design and development, but also important project which we run. And of course, Janet embodies that spirit without doubt, because throughout she has involved lots of patients and carers through her work, and we continue to do so. It is important, and we all clinicians and researchers know that for a fact, and that patients and carers both suffer, whether they have any history in the past, whether they were not distressed before the illness started, or where there is history of distress before the illness started, and there are both sides of the story. But important thing is that anorexia nervosa or eating disorders play a very big negative role on their life, whatever be the background, whatever be the history of the family or the young person or the parents. And we learned today, obviously, that there are different backgrounds which could accentuate the outcome or make the outcome better, etc. But till we find some solution, and lots of research as we speak is happening, thankfully, and lots of collaborations are also happening, and hopefully we'll find some solution for our young people, our adult patients, and also our carers, because without supporting them, I've seen so many lives wilting in front of us. So many families were broken and divorces happening, what we call as social drift. So parents were, or family was in a very affluent situation, but because of change in jobs or loss of jobs, they became poorer, for example. And that had a cycle of negative influence on the young people's life too, because they were not having similar lifestyle as they were having previously. Sometimes moving from private school to government school, which was seen as a negative impact, or loss of social status, for example, or holidays, or the type of outings they could enjoy, etc. So there is always lots of distressing outcome for not only young people and adults, but families, and we have to be mindful of those. We should not always play to what NICE guidelines says. Of course, they are there for a reason, but to look beyond them, what is available, and try to be creative when we are trying to help young people and families or adults is quite important. Thank you, Helen. It is an important point, and we should never forget that.
Absolutely an important point.
Suzanne has some question, I think, Umberto.
Yeah, Suzanne.
Hi, Ashish. No, I just wanted to reiterate what I put in the chat, that just as Helen said, it's always helpful to remember that just as you're not seeing the patient pre-illness, neither are you seeing the family pre-illness. You're not seeing the real us. You're seeing the people who are at the limits of their ability to function. They're worn down with a significant burden of care. Before we access treatment for our loved ones, we're often tasked with keeping them alive, with trying to read the medical monitoring, the economic impacts, which we will talk about later on in our presentation with Agnes and Hope. And I think, the ultimate solution here, as ever, is we need earlier access to evidence-based treatment to minimize the distress upon the whole family unit. Yeah, and just one last thought. I'd just like to highlight that our families are no different to any of your families. You know, in the vast majority of cases, you know, we were living totally oblivious to eating disorders, and then we get catapulted into this universe. And it's important, I think, to treat the caregivers of those with eating disorders just as you would treat the caregiver of somebody suffering from cancer. You know, it's a biologically influenced illness which causes huge distress, and we need a lot of support at a much earlier stage.
Definitely, and there's always a scope of, and that's why in the last few years, lots of work has been happening. And as I have said earlier, that I am quite passionate about offering support to patients and carers, and that was exemplified by what we have started during, you know, just the start of pandemic in 2020. And I would proudly say that we were one of the first services in Northwest, at least. I can't vouch for the whole country, but to start online groups, immediately getting the license to, and you know, secure channels to start those interventions, because patients could not, many of the patients could not come, or the parents, and they were all locked down. And I'm sure going forward, Triangle will bring some new hope and information, Triangle project. And so I'm quite positive about it and look forward to, you know, share the data from it once we have started to enroll patients and deliver the care to them. And Professor Treasure is there to guide us, definitely. So thank you, Susan.
There are somebody other that want to explain their point of view, their comments, etc. Because this kind of topic is very crucial. I think that we have to treat it another time to get in more profound way. In my view, there are two levels almost. There are more than two, but there are most important. There are two fundamental levels. One is the clinical level, where we have to work with the families at a different stage of the illness. But the other is to work with the expert by experience, because we have to rebuild from the environment, from the local environment. And so we're working outside of our studio, outside of our room, clinic room. So we need the alliance with the career, not only because we are new, because we are, as Hélène said before, open, no, because we have to defend democracy. We have to use the knowledge about mental illness, mental health, to improve the quality of the life in our society. This is the reason, because we need to work with the careers, in my view. Okay, there are other intervention. Otherwise, this is a moment very rare. Me, as president of the European chapter, with the intermediate past president, Ashish, and the vice president, Yael. I want to thank everybody. We have to pass to the session on poster session. But before, I want to thank publicly Elisa Meyer. She voluntarily helps our chapter to become stronger. Thanks, Elisa. Poster session. Now, there are, Ashish, you know, is Emilia, the first presenters.
Yes,
okay.
Thank you. I need some help to I'm trying to, okay, thank you. Some moments. Thank you, Umberto. I am Emilia Manzato. I am a psychiatrist. I'll present some results of a multicentric observational study in Italy organized by Italian Society of Eating Disorders on impact of COVID-19 lockdown on the onset of anorexia nervosa in adolescence. Okay. In Italy, in Italy, COVID pandemic was very serious. Due to the COVID-19 pandemic, the Italian population lived in quarantine from March to May 2020. We had a first lockdown with strict norms, deeply limiting social interaction and confining the population at home. In Italy, we had a second, less severe lockdown from autumn 2020 to spring 2021. During the first lockdown, the Italian population was shocked by the images of death broadcast on television. The COVID-19 lockdowns had profound effects on physical and mental health, especially in adolescent patients with eating disorders. The COVID lockdown was a hard period for adolescents because forced the teenagers to have school online, deeply limited the social interactions, essential part of adolescent life, increased the feeling of fear, anxiety, and insecurity, caused increase in social media use. Home confinement has also led to a reduction in emotional regulation factors, such as engaging in enjoyable and rewarding activities. The limit to physical activity and staying at home created, on one hand, more concerns about physical fitness, and on the other hand, more use of comfort food. The next. The centers involved in our observational study were Ferrara, my centers in northern Italy. The center is in a private hospital, Salus, in Ferrara. Central Italy with Pisa, the center of eating disorder is led from Giovanni Gravina, and South Italy, Southern Italy, Naples, University of Naples, Chief Walter Milano. We used the Diagnostic and Statistical Manual in its 5th edition, Criteria for Eating Disorders Diagnosis. We use a questionnaire with a Richter scale to assess the different issues investigated. Back depression inventory and eating disorder inventory tests were administered as well. Informed consent was obtained from all participants and from their parents. Some result, I briefly present you the first, sorry, I can't. Back to the previous slide, please. Okay, and now the seventh slide, I present some result. First of all, the new patients during the COVID pandemic increased by 62% compared to the previous period pre-COVID. And the other results, the other one, please, number 8. The lockdown had a great impact on mood. It worsened the mood of the adolescent. The reduction of direct contact was closely related to the worsening of mood. This is an interesting result because the teenager during the lockdown increased the use of social media to get connected. But in our study, it appears that the communication on the social media alone was not satisfying. The next, please. And furthermore, during the lockdown, adolescents were more worried about eating behavior and about food choices, that is, eating healthily. And lockdown changed also the habits on physical activity due to the isolation at home. Finally, next please. Lockdown increased the attention and the focus on the body image. In conclusion, lockdown greatly increased the risk factor for eating disorders onset on adolescents. Next, please. Lockdown changed also the possibility to receive treatments, and we use our research study for knowing how the patients felt this change. For 64% of the patients, lockdown did not interfere with the treatments. For 86% of the patients, the team support did not change, but once again, only 36% of the patients were satisfied with online treatments. Next, please. Conclusion, COVID-19 pandemic had a severe impact on everybody's life, in particular on adolescents, increased the eating disorders onset and worsened the eating disorder symptoms. But a COVID-19 pandemic highlights also that the direct contact is essential for mental health, especially for mood, and the use of social media does not replace contact for adolescents. Next. Thank you, I finished. Thank you.
But you are mute. Yeah.
Okay, thank you. Thank you, absolutely. Thank you for this presentation, because it enlightens what happened for there will be a project to produce another book about pandemic, what happened in the families, in the adulthood with eating disorder. This is a base, your study. Some questions, someone want to pose? And so we are on time. Is there somebody that has to say some comment? No. Okay, we are on time, perfectly on time. And so we pass now to the chair, Yael. I thank Yael. Yael is the vice president of the European chapter. She's a professor in Israel too. Yeah, okay, she's my friend. Please, Yael.
Okay, hello everybody. Good afternoon. I would like to take this opportunity to thank very much our previous president of the European chapter, Professor Ashish, who contributed to the European chapter tremendously. Thank you very much, Ashish, for your contribution. And I would like to thank Elisha Myers, who joined us from the beginning. She's still part of our European chapter with her spirit and her help, and all voluntarily. Thank you very, very much, Elisha. And of course, to our current president, Umberto, my dear friend, who is doing a great job leading the European chapter. Thank you very much. So we are opening the plenary session 2, which is a new research on eating disorder, presentation from young researcher. And we will start by inviting Albert Jensing. I hope I'm pronouncing the name okay. Shared decision making and automatic motivation in treatment for anorexia nervosa, a new pilot RCT. Albert Jensing, she's from Utrecht University from the Netherlands. Welcome. Alberta, are you ready?
Yes. Can you hear me now?
Yes, we can hear
Yeah,
you.
I'm sorry. Net at that moment, it started hampering. So shall I share my screen?
Yes.
Can you see it now?
Yes.
Yes? Okay, fine.
Thank you. Go ahead.
Yes.
Thanks.
Well, in the first place, I would like to thank the organization of the European chapter meeting for this opportunity to present our study. So thank you so much. I'm Alberta Jansing and I work at Utrecht, which is a big mental health institute here in the Netherlands in Utrecht. And I work on a eating disorder department, Rindveld, and I work there as a clinical psychologist and a behavioral therapist, but also as a PhD student. Some years now, and when I started working here, I was totally ready to learn all about treating anorexia patients. So I wanted to learn, and then I found out that there were actually no treatment protocols at that time when I started working, and the treatment guidelines were limited to only somatic screening, weight restoration, and nutritional management. So what other colleagues were doing, how exactly they were working, I didn't know. When patients were referred after having another treatment, I did not really know what sort of treatment they had. And it makes clinical research into treatment very difficult when you don't know exactly what everybody is doing. But things are getting better. And slowly on, research progressed, and after several RCTs, MANTRA, CBTE, and SSCM came sort of floating to the surface. I think you are familiar with these treatments, but MANTRA is the Maudsley model of anorexia nervosa treatment for adults. CBTE is cognitive behavior therapy enhanced by Fairburn, and SSCM is the specialist supportive clinical management. And because these three came floating to the surface, Barn and her colleagues did the SWAN study to compare those three treatments and see if they could advise one of them. But in the outcome, they concluded that treatments differ in content, but outcome is still comparable. So these three treatments are now in the treatment guidelines for anorexia nervosa. And at that time, it was for our center the reason to implement all of the three treatments. So that's what we're planning to do. But there was no evidence on allocation. So there we had these patients, we had 3 treatments, but what sort of treatment should which patient get? We did not really know. So we discussed this with Susan Barn and with Ulrike Smit and came to the conclusion that the best way to allocate was to have patients make their choice. And we thought that doing this by shared decision making would be the most appropriate way to do so. Said that, the other side of the situation is that treatment outcome is still mediocre, also in MANTRA, CBTE and SSCM. In this one study, only a quarter of the patients met the criteria for complete remission at the end of treatment. So we thought maybe there's a way to enhance outcome even further. And we've done the implementation. And we thought that if we involve patients actively in their treatment choice by shared decision making, this might enhance their motivation for treatments. We of course know that separate motivation interventions often didn't work, but we hoped, as we had to do shared decision making to allocate patients, it also might enhance motivation. And motivation is often known to be ambivalent in eating disorder patients, and patients often come into treatment after external pressure. Parents, physicians, they say you have to go into treatment now because it can't go on any longer. Said that we know that patients who are more autonomic motivated for treatments will profit better from treatments. And autonomic motivation is about your own internally driven goals to change your behavior. So if you think, I want to change because I want to have a better future, that's a better predictor for outcome than if you want to change because your parents want you to. And we thought that thinking about treatments, what do you want to address in treatment? In what way do you prefer the treatments to be shaped? And the whole thinking process might also enhance autonomic motivation for treatment in patients. So we asked ourselves in our study, is it possible to allocate by shared decision making? Is it a feasible way to do this? And we asked ourselves, to what extent does autonomic motivation for treatment in adult patients with anorexia nervosa differ from those who have received a treatment recommendation and those who have explicitly been involved in identifying the most appropriate treatment option for them. So what we did was this. We included 39 patients in our pilot RCT and randomized them over the 2 conditions. The control condition being advice and the experimental condition being shared decision making. And afterwards they would go into MANTRA, CBTE or SSCM. 8 practitioners were involved in these 2 conditions. All were trained. And we used the SDMQ-9 to evaluate the process of shared decision making and autonomic motivation. We used the ACMTQ, and it was assessed directly after treatment choice and after the 1st and 4th treatment session. Well, shared decision making. I think most people know what it is. It's a collaborative process to which the clinician supports the patient to reach a decision about treatment. And it's based on best evidence, clinical features, and patient's preferences. And these 4 steps are really important. Patient is told that there has a choice to be made, and their opinion is really important in the outcome. The options are mentioned. There's a talk about which preferences the patients have, what is important to the patients. And then at the end, there is the process of making the choice. To make sure that all patients had the same information, we made 4 short animation films. We had a folder and we had a decision aids, and all patients in the shared decision-making group were presented with this information. I'm not going to show you the film now, it's in Dutch, so most of you won't understand what it is, but you can see it if you want to. It's on the side of our Utrecht institution. If patients wanted at the end and they said, I'm not sure what I want, just tell me what you think is the best, the clinicians were allowed to give an advice. They had to explain what advice it was and why they would advise this. The other condition, advice, the clinician would speak it through with colleagues, reach the advice together, state the advice explicitly and explain the advice to the patient. And of course, they can't do this on evidence, so they had to do this on clinical judgments. So, and after the data collection, we would check if the 2 groups were the same, and we would check if the 2 groups differ on SDMQ scores, and if they would differ on the autonomic motivation factor. So we found no difference in the 2 groups with respect to age of onset, illness duration, BMI, or diagnosis or gender. So that was a good randomization. On the SDMQ9 scores, the scores of the experimental, the SDM group, were significantly higher than the scores of the control group. So we did succeed in getting more SDMQ aspects into that condition, but we found no effect of SDM on autonomic motivation. There is no effect over time, no effect on condition, and we found no interaction effect between time and condition. So what can we conclude with regards to applying SDM in anorexia treatment? It's a practical solution for allocation, but it did not enhance autonomic motivation in our sample. So, and now there are quite a few questions we ask ourselves after completing this study. The SDM was measured with the SDMQ, and in that way it seems that it succeeded to do shared decision-making in our shared decision-making group. However, this measurement also has its limitations. So we ask patients if they have seen SDM behavior in the clinician. That's what the measurements does. But we haven't asked them if they really think about the process and if they really think about what it means to them. So that's a next step that we would like to take, to ask them how it works for them. We also found that autonomic motivation was high in both groups. And that was, of course, quite a surprise. We expected it to be quite low, and actually it was quite high. So we thought, what is going on there? Is maybe the whole intake coming to our center, talking about your eating disorder, does that already enhance motivation? Is there a selection because patients were already thought to be prepared to go into treatment? So we think about that, what's going on, why is autonomic motivation so high in both groups? And we think that even with high autonomic motivation, not all patients will profit. I think we will probably have the same outcome as in the SWAN study. So other mechanisms in play. Maybe patients are highly motivated if you ask them, but do not succeed in taking the steps that they really have to get better. And we think maybe self-efficacy might be another factor that is in play. So I would like to mention and thank the colleagues involved in this study, Una Danner, Annemarie van Elburg, and Arwen Pietersen. And I would like to thank Esther van Broekhuizen and Demi Waalboer for their help on collecting the data. And I would like to thank you for your attention. So thank you so much.
Thank you so much, Alberta. It seems that you took a great challenge for your PhD dissertation.
It's a small part of the PhD, and it's even more. Yes.
Good job. You did a good job, and I think this is the future. You know, we need to target an automatic motivation from our patients with eating disorder, in particular with anorexia nervosa. I think it's still a big challenge.
Yeah.
And further research is needed. So you started in a good point, but very challenging. And
Yeah.
Thank you for your nice presentation.
Thank you so much.
Okay, we will go ahead. I would like to present Katie Rowlands and Robin Yellowless. They are PhD student from the Eating Disorder Research Group. From the Department of Psychological Medicine, King's College London, and they're going to present a transdiagnostic approach to impersonal functioning and eating disorder symptom in individuals with anorexia nervosa and obesity. It's going to be a comparison of two studies. Thank you very much. Sabrina, Katie, you are presenting, no?
Hi. Unfortunately, Robin was not able to join and share her data today, so I'm actually going to be presenting a smaller proportion of our work, just focusing on eating disorders, so apologies for that. So a slightly different title of the talk, but hopefully still relevant and interesting for everyone. And hopefully we'll hear from Robin at a later stage with her data, which follows a similar area and protocol in people with obesity.
So you are from their group, their research group, Alison?
Yeah, sorry, I'm using my mother's computer, but yeah, it's Katie, and I'm from King's College London.
Okay, great.
Just share my slides. So hi everyone and welcome. Thank you for joining my presentation. Can everyone see my slides? Or let me know if you can't.
Yes, Katie, we can see it. Yes.
Great, thanks. So the title of today's talk is actually Negative Interpretations of Ambiguous Social Scenarios in People with Eating Disorders, specifically in adolescents, in relation to eating disorder symptoms. And I'm going to be talking about an assessment and intervention study, which forms part of my PhD. So just to start with, for anyone not familiar with the term negative interpretation bias, this term refers to the tendency for an individual to interpret an ambiguous social situation as threatening. So an example of this could be you have an argument with a friend and a week later you have a really serious problem and really need to talk to them. You send them a text and they ignore me, for example. So assigning a negative outcome to an ambiguous social situation. One of the ways this is commonly measured in research studies is using a sentence completion task, where participants are presented with a series of social scenarios which are described in an ambiguous way and are open for interpretation at the end. So again, in this example, then participants are asked to come up with as many different outcomes they can think of the scenario in a period of time. So for example, up to 10 completions within 90 seconds. So they're not sort of directed about which outcomes to make, they're just asked to interpret in any way they can within the time frame. So they're presented with, in our study, 10 different scenarios. So they have the opportunity to provide 100 completions in total, so 10 on each scenario. And after participants complete their sort of overall completions on one scenario, they're asked to select which one they think would be the best outcome of the scenario. So which one they think is best completing the sentence. And they indicate their answer using an asterisk on the screen. And then some independent raters who are typically blind to the details of participants in studies, for example, diagnosis, would rate these completions either positive, negative, or neutral. And so 2 or more raters would do this to come up with scores, and there'll be 3 scores per participant. So you'd have a total score, so total negative completions that they made throughout the trials. You'd also have the number of negative first completions, so the very first completion people make, and how many of those were negative. And also how many negative best completions were selected by participants. And so negative interpretation biases have been identified in people with eating disorders, predominantly adults with anorexia nervosa. And this tendency to interpret situations in a negative way has been associated with greater self-reported sensitivity to being rejected socially, as well as more severe eating disorder symptoms. So self-reported fear of weight gain and body image disturbance. And so it's thought that negative interpretation biases may be a mechanism through which the tendency to be sensitive to rejection might impact on eating disorder symptoms. And we think this bias may be present in younger patients with the illness, given that during adolescence, peer relationships in particular become more important, and there's a typical increase in sensitivity to rejection as well. So in a preliminary study involving 24 adolescents with anorexia nervosa who were receiving inpatient treatment, on average, participants selected more negative than benign best completions in this task. But because we didn't include a control group and a small sample, we wanted to investigate this in a larger sample. So the first study of my PhD focused on assessing interpretation biases in a large sample of adolescents with eating disorders compared to a healthy control group. And so specifically, we wanted to find out whether adolescents with eating disorders would demonstrate a more negative interpretation bias compared to healthy controls, and whether this bias would be associated again with rejection sensitivity and more severe eating disorder symptoms as self-reported by patients. So we recruited a sample of 158 adolescents, including a group of patients with eating disorders who are on average age 16, 98% girls. Most of them had anorexia nervosa, but there was a few cases of bulimia nervosa and others. A short duration of illness on average, and about 50% had sort of clinical threshold anxiety and depression comorbidities. The majority of participants were receiving outpatient treatment, but 32% were receiving more intensive treatment at the time of participating. And the control group were screened for lifetime psychiatric disorders and current symptoms. We had significantly more boys in this sample, but when we repeated the analysis without the boys, the results remained the same. So we found that participants with eating disorders did show a greater interpretation bias and heightened interpersonal sensitivity compared to healthy controls. And when we looked at these in a simple mediation model, the tendency to be sensitive to interpersonal interactions predicted eating disorder symptoms, and this was partially mediated by its effect on an interpretation bias. So 20.6% of the total effect was explained by this indirect effect, which provides more evidence to suggest this being a potential mechanism that might be helpful to modify in interventions. So in our second study, we developed an intervention using interpretation bias modification procedures, which were already established in other areas of research, but we wanted to specifically tailor the intervention to the concerns around social rejection of adolescents with eating disorders. So to do this, we first reviewed the literature of studies assessing or training to reduce interpretation biases in eating disorder samples or related samples. We also conducted focus groups with patients with anorexia nervosa, carers and professionals who work in eating disorder services to gather real life examples of social rejection which are relevant to adolescent patients. So we used the materials available in the literature and these examples from the focus groups to generate a large pool of scenarios which could be included in this training task. And our final scenarios were rated as highly relevant by patients. So we asked patients to re-rate these scenarios, and we chose the ones that were the highest in relevance. So an example of a situation where patients felt rejected was organising something with friends, because if you don't receive a reply, you might think they don't want to come. And so we developed the scenario: you invite your friend to sleep over at your house, and they accept your invitation. They don't accept your invitation because they're really busy. And so these scenarios were used to create a multiple session training using this task. So it's the ambiguous scenarios training task, again, which aims to train and reinforce participants to interpret ambiguous social situations in a more benign and neutral way. And it includes 3 different types of trials within each session. So in each training session, 76% of these scenarios are resolved in a positive way, and 12% in a negative way, and 12% remain sort of ambiguous. And so participants listen and read these scenarios on the screen, and then they ask a comprehension question. So if they get the answer correct, they receive correct feedback. So on positive trials, interpreting it in a positive way would initiate correct feedback. And same with negative, if they interpret it negatively, they get a correct response. On catch trials, participants don't receive any feedback. So it retains its ambiguity. So in our third study, we aim to test out this intervention using the materials we developed with the involvement of people with lived experience, carers and professionals, to evaluate whether this training can reduce interpretation biases towards negative interpretations and eating disorder symptoms in people who are receiving, and adolescents who are receiving treatment to a greater extent than those who receive treatment as usual only. So we recruited a sample of 67 participants with an average age of 16, the majority were female with an eating disorder, 94% anorexia nervosa, and receiving predominantly outpatient treatment. And all of these participants were recruited during the first lockdown of 2020, so all during the pandemic online. So to summarise the procedure, we asked participants to complete some baseline assessments, so self-report questionnaires of demographic information, as well as rejection sensitivity, and an assessment of interpretation bias. We randomised them to receive either treatment as usual only or treatment as usual supplemented by these training tasks. So they received 9 sessions of cognitive bias modification training, including this module, over 4 weeks, in addition to their treatment as usual. And then we asked them to complete some outcome measures as well. So as you can see in our consort diagram, eventually we decided to analyse just those who completed the training. So those that were considered completers were those who completed 6 or more sessions of the training in the cognitive bias modification group, and they completed the outcome measures. So we had 22 participants in that intervention group and 28 in the control group. We found preliminary evidence to suggest that this intervention could be helpful, and so we found a greater reduction in negative interpretation bias in the group who received the training compared to the control group. And again, we found greater reduction in eating disorder symptoms in the intervention completers compared to the control group as well. So in conclusion, we found that adolescents with eating disorders report higher interpersonal sensitivity and demonstrate significantly greater interpretation bias compared to healthy controls. The impact of interpersonal sensitivity on eating disorder symptoms was partially mediated by this interpretation bias, and a multiple session cognitive training intervention, which was adapted for adolescents with eating disorders, may help to reduce this negative interpretation bias and eating disorder symptoms. This was the first study to use a multiple session training, so these findings need replication, and it'll be useful considering the variance in how many people completed the intervention to explore the dose response relationship and what factors influence adherence to the training as well. So thanks for listening, and again, hopefully that was interesting despite being different from the original plan.
Thank you very much, Katie. It was indeed very interesting and very important, talking about negative versus positive interpretation. I think it's a key factor for good or bad interpersonal relationship and creating safety. And maybe it's a mediating factor of the loneliness that Treasure was talking about in the keynote presentation. Thank you very, very much. And if anybody wants to ask any question.
Sure, I can. It's a bit difficult to hear, but I'll do my best if anyone has a question.
Okay, thank you very much. So we'll go ahead, and I would like to introduce Sabrina Schroeder. Schroeder, it's okay?
Yeah, that's okay. Yeah.
She's from the Department of Clinical Psychology from Utrecht University from Netherlands. She's going to talk about a very interesting and important topic about eating behavior of women with autism spectrum disorder. And she's going to present a review. We are really anxious to hear.
Oh,
Thanks.
God.
Yes.
All right. Thank you so much. I'm going to share my screen with you. And I need to find my slideshow. All right. Well, thank you for that introduction. I'm going to indeed present my first paper of my PhD project. I am both a PhD candidate and psychologist at the same mental health institute as Alberta Jansing, who just presented about shared decision-making in anorexia nervosa patients. And I'm also a lecturer at the Utrecht University. And my promotion team stems from obviously me, but oh my God, my name is not Annemarie van Elburg, my name is Sabrina Schreuder, but those are the other four promoters of my team. And the reason why we are focusing on, or why my topic is about the eating behaviors of autistic women is because we have noticed a while ago that we have a lot of patients at Rindfeld that come with symptoms that resemble autistic traits. And we noticed that in a certain part of these patients that the treatments that they receive at Rindfeld, whether that be for anorexia nervosa or bulimia nervosa or an otherwise defined eating disorder, they just don't seem to work. And we noticed that they are falling back again into the eating disorder and that they don't really recover. So we thought, okay, there must be a certain proportion of these patients that come at Rindfeld with actual autism. And we kind of also thought, maybe some patients, they show with autistic symptoms, but it actually turns out that it's more caused of the eating disorder itself. So we wanted to, well, dive more into this topic and find out now what's going on here, and can we see differences between how both of these groups eat. So that's kind of how it started. And before I dive into the actual topic of my research, I'm going to give a quick autism detour. And as you probably all know, autism is a complex neurodevelopmental condition defined by challenges in social communication and social interactions, as well as restricted and repetitive patterns of behavior. Currently, we think that around 1.4 to 1.7% of the general population are considered autistic, with reported male to female ratios of 3:1. That was much higher with regards to the male ratio. We are getting better in recognizing women with autism, but we are still not really where we want to be, because we still think, or there's still evidence that autistic girls and women are still often, they still remain undetected and are underrepresented in both clinical situations and research. And that's possibly because their autism looks different than what we are used to diagnose. The diagnostic instruments are usually based on a male phenotype of autism, and we are only recently are getting a feel how it looks like in girls and women. That's why also research how autism looks like in girls and women is really, really necessary and needed. We also know that autism is associated with significant impairments of someone's functioning, and they can have difficulties managing everyday tasks. And autism also often occurs with a range of physical and psychiatric difficulties, such as, for example, problems around eating behavior. There has been a pretty big, growing interest recently in how often that occurs, how many people with autism actually have eating problems. There's also a lot going on in the eating disorder field, how many patients with anorexia have autism or show autistic traits. So there's a lot going on recently, but regarding eating problems in autistic individuals, most studies have focused on autistic children or in autistic individuals with intellectual disabilities. We know that around 44 up to 96% of autistic children experience some form of eating or feeding problems. That is more than typically developing children experience, or children with other developmental disorders. And these eating and feeding problems look a bit like this. There's a lot of food selectivity, picky eating, food neophobia, food refusal. Some of you probably already think, oh, well, that sounds a bit like ARFID, like avoidant restrictive food intake disorder. Yes, that's because it's true. It does resemble the eating behaviors often seen in ARFID. So there's probably a lot of overlap. Some autistic children or autistic individuals with intellectual disabilities eat too much or too little. There's also a lot of emotional over or under eating, more often actually in girls with autism. And there can also be behavioral problems around mealtime. In autistic individuals with intellectual disability, there have been also some studies on pica, rumination, or regurgitation seems to be more prevalent in that. In people with intellectual disability than in autistic individuals without intellectual disability. This is a bit like how it can look like. So those examples are actually taken from interviews I conducted with autistic individuals. They say they don't like slimy foods. They don't like foods with strong smell. So all kind of examples of how their sensory sensitivities can have an impact on how they perceive certain foods, or other parts of their autism, such as sort of like a bit of a frigidity, can also lead to having problems with food. For example, everything has to be separate on a plate, or I don't like to use different cutlery while using. Those are just some examples. Yeah, we think that certain characteristics and patterns of people with autism are underlying these eating problems, such as what I just said, the cognitive and behavioral rigidity that can make it difficult to eat new foods or try out new foods or eat in a different way than they usually are used to eat. Sensory sensitivities play a role, or their restrictive interests and repetitive patterns in behavior. I will come to that in a minute, how that can look like. So these eating and feeding problems frequently seen in autism can have pretty big consequences. They can lead to a lot of gastrointestinal problems, over and underweight, and nutrient deficiencies. And these problems have been shown to persist into adolescence and adulthood. But studies into the eating behaviors of autistic adults are lacking. And those that have been done do show that these eating behaviors are more frequent in autism than in control populations. Adults also struggle with being overweight or obese more than controls. And especially autistic women, even though there's very, very, very little research on this, seem to struggle not only with these frequent seen in autism, but also with increased eating disturbances associated with the traditional eating disorders. For example, a pathological avoidance of certain fattening foods in order to, because of a fear of gaining weight, the desire to be thin, and bulimic behaviors have also been associated with autistic women. However, as I just said, most studies either have included very, very few women, are not providing separate information for autistic men and women, or have included autistic women with intellectual disabilities. And that is a problem, because if you then want to investigate these eating behaviors and compare them, you can't really say, okay, do these eating problems come because of the intellectual disability, or is it because of the autism? So because there's so little known, I wanted to dive into the field and find anything I could find of what is known about eating behaviors of autistic women. And I was pretty strict with my inclusion criteria. I decided to only include studies where it is really clear that someone has a diagnosed autism spectrum disorder, so no self-report, no autistic traits, really diagnostic assessment according to the NICE guidelines. But other than that, I was really open. I wanted to just see what is out there knowing about the eating behaviors of these women. I manually scanned 3,858 abstracts. I felt like a German machine, because I'm German, and I felt like a German machine going through all these abstracts by hand. And of all these abstracts, only 4 were really about women that have a diagnosed autism spectrum disorder, and that where something has been measured regarding their eating behaviors. And those were 3 cross-sectional studies and 1 case study, and they measured different types of eating behaviors. As you can see, the EDEQ and the E26 were used in these studies to measure disturbed eating behaviors or eating pathology. And eating behaviors frequently seen in autism were assessed in these studies with the SVEA, that's the Swedish Eating Assessment of Autism. And one study I found about women and their weight and body composition. The study only collected BMI data, which I was also interested because obviously that is related to eating problems. So across all these 4 studies, I found that autistic women displayed high levels of, I call it problematic eating behavior, that is both eating behaviors frequently seen in autism and eating behaviors associated with the traditional eating disorders. So they did show high levels of problems with sensitivities regarding the sensory properties of food, having rituals and routines around meal times. They found it difficult adapting their behavior to other people present during their meal times. They had very rigid preferences with regards to brands of food, so only certain brands of foods will do. So that was kind of unsurprising. That was in line with previous research that these eating behaviors frequently seen in autism, that they do extend into adulthood and do extend into women with autism, of autistic women. So also this kind of resembles orphotic eating behaviors. But these studies also showed that, yeah, they did also suffer, or they did report disordered eating behaviors, such as the avoidance of foods because they were afraid of becoming fat or gain weight. They had a desire to be thin. They were dissatisfied with their body. They displayed bulimic behaviors. They showed preoccupations with food. And some studies compared their their disordered eating behavior levels to women with eating disorders. And it was actually very interesting that autistic women did reach similar levels of eating pathology, not quite like women with eating disorders, but similar levels. This is, of course, very worrying because this suggests that these eating problems that have been frequently seen in autistic girls, they do persist into adulthood. And that gives rise to the assumption that autistic women might be especially vulnerable to develop a range of disordered eating behaviors or already suffer from undetected eating disorders. We reviewing the results or the findings that I found by scanning all these by diving into these studies, is that we think that certain ASD related characteristics and processes are likely to play a role in the development and maintenance of these behaviors, such as the problems with sensory processing, the engagement in restrictive and repetitive behaviors, and the cognitive rigidity. These eating behaviors, such as, for example, the avoidance of certain foods because of their texture, smell, taste, could be because of the hyperreactivity of autistic women, that they try to avoid certain foods because it adds too much to the sensory overwhelming sort of. There could also be the fact that some autistic women seek sort of they engage in sensory seeking behavior, so they over consume certain food items because it feels good in their mouth, because it stimulates, it's a nice stimulant. This is supposed to be hyporeactivity, by the way. So kind of a mixture between avoidance and sensory avoiding behaviors and sensory seeking behaviors, and their behavioral rigidity resulting in sort of the having preferences for a particular brand, or engaging in dietary behavior because it is sort of their restrictive interest. But also other problems, such as difficulties with emotion regulation, might trigger these eating behaviors. It could be that increased emotional overeating is a strategy of self-stimulation to cope with negative emotional or cognitive states or stress, similar to those of women with eating disorders without autism. There could also be emotional undereating to cope with overstimulation by avoiding additional sensory information of food. So those are just some ideas why these eating behaviors are so prevalent in autistic women. This one study that included weight and body composition data did not reflect any big changes or like big differences in weight of autistic women. Their BMIs were sort of in the normal range, but that's also just one study that that I found. So we conclude that obviously autistic women not only suffer from eating behaviors frequently seen in autism, but also from disordered eating behaviors. It is unclear yet which mechanisms underlie these behaviors. So there's a need for more research into, okay, how do these eating behaviors, these problematic eating behaviors, both eating behaviors frequently seen in autism, but also the disordered eating behaviors, how do they exactly look like in autistic women? Do they resemble the behaviors of autistic women with intellectual disability? Because I did not include any women with intellectual disability. Are they different, or do they resemble the behaviors of women who have eating disorders or feeding disorders such as anorexia nervosa, bulimia nervosa, binge eating disorder, AFID, who don't have autism, in order to ultimately adapt the current treatment modalities. Oh, sorry. And I am trying to answer all these questions by means of a next study where I compare exactly these eating behaviors of women with autism that do not have an eating disorder. I compare these to women who have an eating disorder who don't have autism, and to those of women who have both. And then I'll gladly present my findings at the next European chapter meeting, because I hope will be done soon. So if you have any questions, I'm happy to answer them now, or you can always reach me. Yeah, that's it.
Thank you very much, Sabrina, for the brilliant review about this important topic. And we will still ask the question that you are asking, and we are looking forward to hear about your further research on this topic. Any question? Okay, so I would like to thank very, very much the three brilliant PhD students for their presentations. And I would like to pass on the lead to my friend Kashish Kumar.
Thank you, Yael, and thank you for the researchers who presented their findings in their talks. Now, this is the opportunity for to invite Dr. Agnes Ayton, the Vice Chair of, Chair of Faculty of Eating Disorders of the Royal College of Psychiatrists, and she's a consultant psychiatrist, works in Oxford in UK, and also does lots of research, teaching, training, and motivating young generation to do well in their career. And also it is a dual act. So I'm going to invite Hope Vargo, who is a very famous public speaker, and she works with people with eating disorders, with lived experiences, and also helps government bodies and businesses to help educate them about eating disorders. She also works quite passionately with politicians in UK and different public figures to promote the idea of having more funding, opportunity of having more research, improvement of clinical services within UK. And our dear colleague from Suzanne Baker, who is the member of the Faculty of Eating Disorders at Royal College of Psychiatrists, and also from FEAST. So they're going to present on the economic cost of eating disorders in the UK, which was part of a amazing study. So welcome, Agnes, Hope, and Susan.
Yeah, well, thank you very much for inviting us. And I asked whether it would be possible to share our slides because my technology is not that great, I'm afraid. And we are still waiting for Hope. I think I can't see her on the list. Has she joined?
So Liz, do you have the slides to share?
I think Elisa has very kindly offered to share for us, or one of the members. So if you could help them with.
Shall I do yours, Agnes? What you sent me, is that the same one, or?
Yeah, it is the same one. Thank you.
We are waiting for Liz.
Multi-purpose. Multi-purpose story. Thank you. I'm just a little bit anxious that Hope hasn't joined, so I don't know. Suzanne, do you want to start and step in?
Yeah, I can absolutely do that. I've just texted her, so hopefully she'll come along at some stage. Yeah, as Ashish kindly invited us, we are here representing the Hearts, Minds, Genes Coalition, which is made up of various individuals. Agnes as the chair of the Royal College, Jerome Breen as Professor of Genetic Psychiatry at King's, Hope Virgo, the campaigner, Simon Brown, another parent representative, and myself, Suzanne Baker, as she said, who is, I am the care representative of the Royal College of Psychiatrists. I represent FEAST here in the UK, and I also sit on the Expert by Experience Committee of the AED. We all came together to basically change the story around eating disorders. We all know that about the stigma and the misunderstanding that remains in in the world at the population level, and the lack of funding, the fact that eating disorders are hidden in plain sight. The campaign that we launched is called Anybody and Everybody. We know that eating disorders are not always seen. We know that we believe in recovery from an eating disorder is possible at any age and at any stage. And we're seeking to highlight this at a population level. We want to work towards removing the stigma, or sometimes we call it discrimination, and misunderstanding that surrounds these illnesses. We know that there's no one look to eating disorders. They're often hidden in plain sight, and they occur at any age or any stage of life, in any gender, ethnicity, body shape or weight, sexual orientation or socioeconomic status, which I know everyone here knows that, but just outlining what we hear and what we stand for. We want to ensure that no one with an eating disorder should experience shame or guilt for suffering from a biologically based illness, and that everybody should have timely access to specialist services. Next slide, please. As Janet said earlier, with a massive rise in cases during the pandemic, there's been a huge knock-on effect of delays in accessing treatment, and we're therefore seeing a rise in avoidable chronic long-term illness and loss of life. We all know that we urgently need more data to present to policymakers to make a compelling case for additional funding, which I know Agnes will talk to you about at a later stage. We also know that there are low levels of research and healthcare investment in eating disorders, given the burden of these illnesses, and also a lack of studies focusing on improving outcomes. Janet highlighted earlier the importance of collaboration and co-production with lived experience, and examples often cited by the carer lived experience, of which I'm one, are that, for example, target weights in treatment. If target weights are set too low, then is recovery really achieved? We also see that the need for a dashboard to monitor outcome targets. Above all, we all know here that, and we're only too well aware, that eating disorders are not being tackled as a matter of urgency, probably worldwide, but I'm really speaking here of the UK, which is our exact experience. Next slide, please. In 2021, the Hearts, Minds and Genes Coalition, led by Hope, produced a report with the support of Ernst & Young to estimate the social costs of eating disorders in the UK during the time between 2019 and 2020. The study sought to produce an estimate of some of the social costs of eating disorders to England and the UK. A cost of illness study, as I'm sure you all know, typically seeks to identify and measure the costs of a particular disease, including the direct cost to the patient, the indirect to society, and also the intangible dimensions, the quality of life impacts. The output of our report is expressed in monetary terms and therefore provides an estimate of the total burden of a particular disease to society on the affected individual, healthcare system and wider economy. So for the purpose of this study, social costs have been defined as healthcare costs, in the case of the UK, both NHS and private, costs to the individual, productivity costs and costs to informal carers. It's important to note that these estimated social costs do not include the quality of life impact, so as such do not represent an estimate of the total social impact. The study was based on secondary data, and the first step was to establish prevalence of eating disorders in the UK, and we're all aware there's currently no detailed population-based prevalence study of the number of people living with eating disorders in the UK. Therefore, this analysis has been drawn from a number of prior studies and official statistics to estimate prevalence. The second step was to establish an estimate of the healthcare and non-healthcare costs per person living with an eating disorder. And the estimates were drawn from literature. The cost per sufferer was then scaled to the estimated population to calculate the potential select healthcare and non-healthcare costs of eating disorders in the UK in 2019 and 2020. Next slide, please. So the conclusion of the results of the study estimated that there are between 1.2 to 1.9 million people living in England with an eating disorder in 2019, and extrapolating the underpinning prevalence rates to the full UK population would suggest a UK figure of between 1.4 to 2.3 million people. But as we know, there's evidence to suggest that the number of people with eating disorders is likely to have grown in 2020, a significant increase in the number using specialist eating disorder services. Based on the estimated range of prevalence from low to high, eating disorders could have generated social costs in 2019 of between 5.9 to 9.0 billion pounds, and in 2020 to 6.3 billion to 9.6 billion. These imply an average cost per affected person of up to 5,000 per year. So to conclude very quickly, this study has demonstrated that eating disorders are likely to be highly prevalent in the UK, and that NHS spending on eating disorders is a relatively small amount given their prevalence. Given the success of early intervention, as we know, increasing spending on healthcare in this area may reduce the broader social costs imposed by these diseases. And just as our campaign is to highlight that eating disorders are often hidden in plain sight, so too are the costs. The costs are so often hidden, with the burden of care falling on the patient and the whole family unit, the whole economic and emotional fallout, the travelling costs, often exacerbated by out-of-area placements, loss of earnings, loss of potential earnings, loss of careers and jobs, and all too often the hidden costs, the emotional well-being of siblings and other family members. It's evident that further evidence is required to determine the true costs of eating disorders, as this study is likely to underestimate the costs. I'll now hand over to Agnes, who will talk further to you about all our work.
Yeah, thank you very much, Suzanne. And if I kind of continue with a little bit about the limitation of the study. So as Suzanne said, we were estimating the cost to the UK about 9.4 billion. But because we haven't got a detailed population-based prevalence study, this is uncertain. What I would like to say, and it's a shame that Hope hasn't been able to join us, but with the support of Hope and multiple campaigners, including the Hearts and Minds and Genes group, we have now reached a position when we have funding for the next adult psychiatry morbidity survey, where hopefully we will have the first ever detailed epidemiological study of adult eating disorders, so 16 upwards. So that is a significant progress, and watch the space of the results of that. The other thing which is important to note in the UK, and I would imagine that other countries are in a similar situation, that we have a incomplete data collection. So, for example, we weren't able to collect data on accident and emergency attendance, dentistry attendance, medication use, state benefits specifically for people who are unable to work because of an eating disorder, and also because of premature mortality. And we're also acutely conscious that even with the current kind of screening tools of what we have available, probably the prevalence is an underestimate, because people don't necessarily come forward because of self-stigma. And also there is a stigma within the profession itself. So the recording of eating disorders is incomplete. And unfortunately, I see that every day in my clinical practice, when even deaths are not recorded appropriately. So this is something that we need to address in the future. So shall we move on to the next slide, please? So what does this all mean? So a cost of illness study tells us a little bit about what is the overall cost of a specific illness, but that doesn't actually bring us a solution. It highlights the magnitude of the problem. And since we've been working on this, we kind of started realizing we actually have a lot of good guidelines in the UK. We have the NICE guidelines, which were published in 2017. We have the SIGN guidelines, which were published this year. And the National Health Service published various guidelines about high quality services in the last few years, initially for children and adolescent services, and then more recently for adults in 2019. However, what is missing is investment to implement these guidelines. Can you just go back, just remain with the same slide? The investment needs to be targeting improving staffing levels for service, because all the evidence-based treatments, as you know, require qualified staff for psychological treatment. And we also need prompt access to treatment without barriers. So in the UK, we have this really strange lack of parity, and I would be interested to know what's happening in other countries, that children and adolescents or young people under 18 can have access to treatment within a month, even if they are not particularly urgent. And then in the case of an urgency, that they can be seen within a week. Although having said that, and Ashish will tell us in more details, since the pandemic, this has been difficult to meet this guidance. But nevertheless, this guidance exists, and it's being monitored nationally. Whilst after 18, patients quite often put on 2 years waiting list or can't access evidence-based treatment at all. Many services, including my own in Oxfordshire, in a situation when we have to exclude patients simply because of insufficient staffing levels. So underinvestment costs lives and it costs suffering. And I would say it's also not cost effective. So if we move on to the next slide. One of the data which are collected is by NHS Digital, looking at the hospital admission with primary and secondary diagnosis of eating disorders. And I think this is a really important slide because it shows that there has been a trend of increasing need for hospitalization for more than 10 years. So yes, the pandemic has had an impact, but we have seen an increasing trend over the last decade. And the trend has been pretty consistent. So I think it's unrealistic to expect that it will change anytime soon. I would also say that because quite often we are asked a question from politicians, well, do you think that people are admitted to hospital because there is more awareness of eating disorder? And you know, anyone who works in the field or anyone who has a family member with an eating disorder knows full well that people only get admitted in a life-threatening situation, certainly in the UK. More recently, we have seen kind of patients presenting to hospital with a BMI of 8 and 9. So you're talking about really dangerous presentations. And one does wonder whether if we had better investment and earlier access to treatment, whether this trend could be reversed. But it's really important to say, well, it's not either or. So it's not a zero-sum game that we stop hospital admissions and that money can be spent for community treatment. We need investment into both high-quality community services as well as high-quality inpatient care, and we need to have integrated care which has better outcomes. So if we move to the next slide, again, I'm sort of quite curious what is the situation elsewhere. This is from a recent audit that we've done involving 13 adult services, community services, representing 11 million people in the UK, just at the beginning of the pandemic. So looking at whether these specialist eating disorder services can meet the required standards by NHS e-guidance. And some of the answers which I highlighted here are quite shocking. So only 31% of services can accept referrals of all presentation with eating disorder. And BMI being one of the most common exclusion criteria. And it's just totally unacceptable. Hope has been the campaigner for Dump the Scales campaign, because you know, it is just heartbreaking to having to exclude someone with a BMI of 17 or something because of lack of resources in the service. And it wouldn't be acceptable for any other illness. So in case of cancer, you wouldn't say that well, you're not severe enough, so come back later when you deteriorate. We know that early intervention helps, and we know that the majority of the patients can benefit from treatment. Quite often services are unclear about how many people need help in their own geographical area, because obviously there are variation depending on whether it's rural or urban areas with big universities, etc. The vast majority of services have a long waiting list for treatment. Less than half of the services can offer treatment for people with significant comorbidities such as autism, substance misuse, or personality disorders. And staff are feeling unsafe. So staff are reporting that only 62% feel that they have enough capacity to manage risk safely. And I think this is really quite serious and sobering. I suppose the other issues that I would like to highlight, that transitions, again, less than half of the services can ensure seamless transition. So I'm talking about transition between children and adolescent services, inpatient and outpatient treatment, or moving areas, which are all associated with increased risk. And only 23% of services feel that they have skills and training to support patients with diabetes and bulimia.
Sorry, Agnes, couple of minutes only. Sorry.
Yeah, I have actually finished. So moving on to the next slide. I don't know whether Hope is joined us or whether you want to finish. Suzanne?
Yeah, I can finish. Thanks for that, Agnes. So, yeah, you know, as a coalition, we've been really fortunate in the last couple of weeks. We've visited number 10 twice, the second time of which was the first time was to meet with the Prime Minister's Special Policy Advisor, and the second time was to meet with the Minister for Mental Health. And with, you know, leading people in the NHS England, Tim Kendall, and people from NICE and everyone there as well. And what we were calling for in the immediate term is emergency funding to stop the current eating disorders wave becoming a long-term burden on society in the NHS, the funding of a 5 to 10 year programme of multidisciplinary research, and the real need for data and reporting, true data and true reporting around eating disorders. Next slide, please, just to quickly whiz through to the end. You know, we're continuing to campaign for improving funding to ensure parity and equality. And at that second meeting, you know, there was the usual thing of, you know, we can't just give you money unless you've got compelling reasons. You know, Agnes has talked about that, you know, clinicians now feeling unsafe. And we did raise this with them as 2 compelling reasons. We sort of said, you know, patients are now not only not ill enough, but they're too ill for community, leaving so many people unsupported. And as we know, the rising levels in suicidality due to this lack of support, and also the huge workforce crisis that is upon us and is looming even greater. And, you know, when clinicians are feeling unsafe as well, that's a really urgent call for you know, so much work needed on workforce and to attract people to the profession for credentialing and more. We need joined up services and research. We need to work on prevention at a population level, and then with the environment, we're working with Instagram, who are helping us on this campaign for the next year. And we need to engage with the relevant stakeholders, and not to forget the training for undergraduate and both postgraduate individuals. So thank you all for your time. I'm sorry that Hope couldn't join us, but I hope we've given you a quick overview of the work we're doing.
Thank you very much, Agnes and Susan, and we missed Hope. Thanks for a great talk, and covered lots of areas which are very important to patient care and supporting the clinicians and research and everything. We have run over time, apologies for that, and so we would not have time to ask questions, but Agnes and Susan, if you could stay back, I'm sure people may want to ask questions, but we will keep it towards the end of the session. At that point, I'm going to invite Professor Cynthia Bullock, who has multiple hats, globally renowned geneticist, and of course, very passionate about eating disorders. She has done lots of research in that field, and she is from University of North Carolina, Chapel Hill, and where she heads, or she's the director for eating disorder services, as well as professor in nutrition and eating disorder both. So multiple hats, very passionate about eating disorder, has taught generation of professionals as well. And we are very fortunate to have you here, Cindy, and over to you. And apologies for being a bit late. Thank you.
No worries at all. Hi, everybody. Lovely to be here. And thanks for that introduction. And I will share my screen and go to the slideshow. And if someone could just give me a heads up or a thumbs up to say that the slides are progressing.
Yeah, it is
Awesome.
great.
Awesome. 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 Okay. All right. Eating disorders, genes, and environment, hot off the presses. So basically, I'm going to walk you through these steps today. A reminder of where we are now. So the FREEZE 2 results very briefly. What's happening with the FREEZE 3 of the Psychiatric Genomics Consortium Eating Disorders Working Group. Talk about the transition from ANGI to EDGI. A section about representation and inclusivity, which is very important at this point. Some information on our community feedback programs, and then what's happening with EDGI. So we'll start with FREEZE 2. I think by now everyone has probably seen this slide. This was the last genome-wide association study that we published, in which we identified 8 significant loci or areas on the genome that were significantly associated with anorexia nervosa. And many of them had previously been identified to be associated with other autoimmune, metabolic, neuropsychiatric, and sex hormone traits. And then I think the slide that even got more press than our GWAS slide was this genetic correlation slide, in which we showed that not only does anorexia nervosa have many positive genetic correlations or associations on a genetic level with other psychiatric disorders, especially OCD, it also showed significant negative genetic correlations with various metabolic and anthropometric or body measurement traits. And this sort of led us to the point of saying, maybe to truly understand anorexia nervosa, we need to be looking concurrently at the psychiatric and the metabolic component. But even though this was a lot of work, it was very much the first step. And so now I'm going to jump forward a couple years and summarize what we've all been doing in the background, getting ready for FREEZE 3. So FREEZE 3 is happening right now. Our chief analysts for this are Melissa Munchernoff from UNC Chapel Hill, Jet Timmershausen from Karolinska Institute, Helena Davies from King's, and Lee Sang from King's, under the tutelage of Johnny Coleman and Jerome Breen. And just to show how this FREEZE is going to differ from the last FREEZE, the slides I just showed you were from almost 17,000 individuals with anorexia nervosa and 55,000 controls, which, as far as a genome-wide association study goes, is a pretty small sample size still. So we've been collecting additional samples around the world so that this FREEZE will include over 24,000 individuals with anorexia and 830,000 controls. And of course, having a larger control group just really helps your sample, helps your power, and just helps your analysis overall. We know from these groups that we definitely have about 3,000 individuals who are restricting anorexia nervosa, about 6,000 who have the binge purge subtype. And given that our sample size for bulimia and binge eating disorder still isn't adequate to do a genome-wide association study, what we decided to do is actually sort of drill down and do a GWAS on binge eating behavior. So we have a narrow definition of binge eating, for which, for most intents and purposes, sort of parallels what we see in the DSM in terms of frequency and duration. And then we have a broader binge eating definition that is less strict in terms of the duration and the frequency, about 29,000. So that should be a fairly well-powered genome-wide association study, provided it really is a solid phenotype. So our numbers are going up. And this is just an idea of what the new cohorts are. So when we look back into FREEZE 2, and I'm not going to go through all these definitions, it really is just to illustrate where our samples are coming from. You see lots of samples that are coming from European ancestry populations. And actually the same holds even for FREEZE 3. We're seeing a lot more samples coming in from the UK and samples coming in from other European countries. We do have 2 Asian populations. We have a Japanese sample and a Korean sample, but they are unable to be included in the primary analysis at this point and will only be included in the analyses in which we're looking at polygenic risk scores. More on that later. So when we talk about this leap of how we're going from Angie to EDGI. I think most people are aware that Angie, which was a study funded by the Klarman Family Foundation in the States, contributed the majority of samples to that second freeze. We are now looking forward to freeze 4, focusing more on the Eating Disorders Genetics Initiative, which has broadened our search space in looking for genetic factors contributing to eating disorders. So for EDGI, the original study funded by NINH focuses on anorexia nervosa, bulimia nervosa, and binge eating disorder. We have gotten some preliminary information that we will also get some funding in the United States for ARFID. And the United States didn't fund atypical anorexia nervosa, but we have managed to collect samples on atypical anorexia nervosa in Sweden, the United Kingdom, and Australia, because I think there's a very important fundamental genetic question that we can ask to understand whether sort of the behavioral and cognitive features of anorexia nervosa, when they occur in individuals in larger bodies, genetically, are they actually the same as when we see anorexia nervosa in individuals with low weight? So I think it's a really important question, and I'm super grateful that other countries are able to collect these data. Now, a little history about this pending ARFID. We first put this grant in, I think, 2 years ago, at which point the National Institute of Mental Health said, we're not convinced this is actually a heritable phenotype, so we don't really want to invest a lot of money in doing a genome-wide association study of ARFID yet. So we went to the very useful, in this case, Swedish registers, and Lisa Dinkler, who was a postdoc at Karolinska, did the first ARFID twin study. And she looked at 34,000 twins using the child and adolescent twin study in Sweden, or the CAT sample. And she pulled together psychiatric and neurodevelopmental phenotypes and linked the twin study to the population health registers. And she did the standard twin model that I think we've all sort of heard about before the world has moved toward GWAS, to sort of justify why we're actually looking for genes in these populations, and came up with the first heritability estimate for ARFID. And basically in these ACE models, you're looking at large samples of monozygotic and dizygotic twins, and you're fitting a variance components model that comes up with A estimates, which are additive genetic, C, which you don't see here, which is common or shared environment, and E, which is unique environment and an error term. And what she found was that the heritability of ARFID is about 69%, which actually places it amongst the most heritable of psychiatric phenotypes. So armed with these data, we went back to the NINH and said, you know, it's a heritable phenotype, would really love to have some money to include ARFID in these global studies of the genetics of eating disorders. But what else we're doing in EDGI that's different is globally, we're trying to reach 100,000 cases. We're using the same questionnaires around the world. So we're really trying to harmonize this so that we can have parallel studies in multiple countries. We're diversifying the samples. We're using all digital consent and questionnaires in the countries that allow it. So several of the countries are letting us do online consenting, online questionnaires, without having a phone or a Zoom or a face-to-face meeting with the participants. Other countries have not taken that step yet. Simple at-home saliva collection. And Angie, people had to go out and have their blood drawn and have the blood sent back to a central location. But the technology has advanced enough so we can now just send them a spit tube, people spit at home and then pop it back into the mail. And then we're engaging the advocacy community, and we're engaging clinicians and really trying to excite people about being part of this global research. And we're engaging clinicians so they can let their patients know about EDGI. So another thing that we're doing that's different is in Angie, we simply assessed eating disorders diagnoses. We have decided that this, especially since it's all online, is a prime opportunity to really get deep phenotyping on all of the participants. And in some ways, COVID worked in our favor because this study launched during the pandemic, during the peak of the pandemic, and a lot of people were stuck at home, and they were actually fine with filling out a lot of questionnaires. It gave them something to do. And so what we're assessing are life events, trauma, physical activity, obsessive compulsive symptoms, alcohol and drug use, tobacco use, including vaping, anxiety, depression, and treatment history. And treatment history is tailored for each individual country. And what this battery of tests is going to let us do is really dig deeper into understanding genes and environment. So looking at both the action and the co-action of genetic and environmental factors. And this is just a more detailed list of the phenotypes that we're getting. The other thing that this is letting us do is collaborate with the other psychiatric genomics consortium groups. So for example, having lifetime alcohol use, having lifetime drug abuse, lets us combine our information with the PGC substance use group so that we can really boost power and look at relationships across the different disorder. And a lot of this work is being done by Melissa Munchernoff. But if you recall looking at those samples that I showed that were included in freeze 1 and freeze 3, what you will have noticed is that the vast majority of the samples come from within these 3 purple circles. They come from the US, they come from Europe, and they come from Australia and New Zealand, which means they are all European ancestry individuals. So how can we possibly know that the same genetic and environmental factors influence risk for anorexia nervosa, bulimia nervosa, binge eating disorder, or ARFID in Sweden, in Brazil, in India, in Malawi, if we don't measure them? So this is basically saying that we're sort of setting ourselves up at this point for only a very partial answer to the impact of genetic environmental factors on eating disorders if we continue to only sample individuals from within these purple circles. So that has been one of our driving principles. So first off, it is essential to have representation from diverse populations to ensure that we don't perpetuate or amplify health disparities. So for example, someone might not be muted. I'm getting a lot of background noise. Okay.
Can we please mute? Sorry, can we please mute? Thank you.
Okay, that's better. Okay, so for example, if we stopped right now and all of our samples were from European ancestry populations, and we happen to have strong enough findings that actually led to a pharmacological agent that helps recovery in anorexia nervosa. So it makes it easier to renourish someone, makes it easier for someone to sort of overcome the cognitive aspects of eating disorders. It's possible that that will only work on people who come from that same ancestry, so a European ancestry individual. We're ignoring the fact that there are likely different genetic factors and definitely different environmental factors that might contribute to eating disorders across different ancestry groups. So to fully account for both genes and environment, we need to make sure that we are collecting samples broadly on sex assigned at birth, on gender identity, on weights and shapes, on genetic ancestry. So race, ethnicity, ancestry, whichever language you like to use. We use ancestry because we're really looking at the genes to tell us where a person came from. At culture, at socioeconomic exposures, and at life events. And I think people often talk about genetic differences that might influence risk for eating disorders, but we really have to think about environmental differences that influence risk for eating disorders as well. Because right now, everything we know about that pretty much comes from the experiences of people with European ancestries. So we really have to do a better job at representation in our genetic studies. And as an example, I'm going to talk a little bit about what we've done in terms of recruiting people of Latino or Hispanic ethnicity in the United States. And from the beginning in EDGI, when we started this study, we were determined to engage the community. For example, in the United States, we included Spanish speakers on our study team, and we dedicated funds to create parallel recruitment campaigns in English and in Spanish. We have a duplicate website, we have all of our questionnaires translated and verified in Spanish, and we have parallel social media accounts that don't necessarily have the exact same content, because there's also sort of adaptation that occurs in those. And if you look here, it has been highly successful. And NIH gives us, in their quotation marks, minority recruitment goals. And the purple line down here on the bottom is what our goal was for recruitment from the Hispanic population. And as you can see, we have far exceeded our enrollment goals for the Hispanic population. And interestingly, a lot of that came through Facebook and Instagram, which seems to be a very effective way of reaching the Latinx population in the United States, as well as an organization called Research Match, in which people sign up to participate in research. So I think our approach has been effective. And interestingly, even though we have the questionnaires in both languages, many people of Latinx background have chosen to complete the questionnaires in English as well. But having that questionnaire available, I think, is a really important component of our outreach. We've also condensed all of our approaches, which are much more complex than I just conveyed, in a study that we hope will be published soon called Recommendations to Encourage Participation of Individuals from Diverse Backgrounds in Psychiatric Genetic Studies. Because there are many barriers to participation that need to be addressed carefully and comprehensively in order to ensure that we're really broadening our recruitment. And so these are some of the things to think about. One is to really recognize and center unique experiences and challenges and concerns of individual underrepresented communities across the lifespan. And that's actually really important because, you know, someone who is a first-generation person from Mexico in the United States is going to have a very different experience from someone who is a third or fourth generation Mexican in the United States. Really focus on co-design strategies throughout the research process. Before you even submit your grant, do community feedback so that you can understand what you should and shouldn't do in trying to reach individuals from underrepresented communities. Be mindful of language. And I think this is really important because language changes. Language has changed during the course of our study, and we've needed to sort of revise some of our outreach materials to really stay up to date. And that is, you know, using language like African ancestry or Black. And we find a lot of complicated things that we need to work around in terms of talking about weight, whether we talk about people with higher weight or from larger bodies, or the fat community has reclaimed the term fat. So there's a lot of things to consider when creating your materials. And also be informed about historical, political, and cultural contexts of genes and genetic research, and respect the community's terms for participation. And then finally, this is not cheap. And it's important to budget in your grants adequate funds, time, and effort for recruiting diverse populations. It's not the kind of thing where you just throw up a website and then people all of a sudden participate. It's an active process, and you need to keep your energy high in order to continue recruiting. And then the other part is transparency. And it's important to address hesitancy directly. And we found this especially with the African population in the United States, where there has been a lot of distrust of the healthcare system, as well as discrimination, stigma, and intergenerational trauma. And it's best not to shove those things under the carpet, but be upfront about them, have conversations about them, and be open to talking to potential participants who have concerns. And then demystify the research process with written audio or video materials. So we have a step-by-step video of what it means to participate in EDGI and what happens when your spit kit arrives in the mail and how you spit into it and how you send it back, so that people can really sort of insert themselves into the process ahead of time to understand what participation actually means. Make the research transparent and accessible, and be forthright and genuine about potential breaches of confidentiality and their potential impact. I think so often we overstate how confidential our research is. So it really is much better to just say, yes, a breach could occur. It's highly unlikely, but it could occur, and this is what the outcome could be. And here is where I want to spend a little bit of time talking about both Swedish and US data and what has happened. EDGI in Sweden has been enormously successful. As you can see, over 10,000 people have already completed the survey since sometime in 2021, since January 2021. And a lot of them are sending their saliva back, and over 50% of them have also agreed to participate in our microbiome study, which is they have to submit a stool sample in the same way that they submit a saliva sample. So that's a really big population. But something stands out as odd, and I'm going to throw some circles in here. So first off, over here on the left, you can see that the number of diagnoses that people have, 5,000 with 1, lots of people have had 2, and a bunch of people have had 3 eating disorders diagnoses during the course of their illness. In every study, however, we're starting out with Angie, we had a surplus of people with anorexia nervosa. That was by design. We looked for that. In the quality registers in Sweden, we also have an overrepresentation relative to the population expectations of anorexia nervosa, with a lot more people with anorexia registering for treatment than bulimia or binge eating disorder. And from the general public. So when we use social media to recruit people, we still access many more people with anorexia nervosa to participate in the study than we do for bulimia or binge eating disorder. And as you know, that's the opposite of what we expect in terms of the prevalence of these disorders. We should have much higher numbers of people with binge eating disorder than we do of people with anorexia nervosa. And interestingly, even in the BEGIN study, which was the Binge Eating Genetics Initiative, we had as many people with anorexia participate as we did people with bulimia. And that study specifically targeted people with bulimia and binge eating disorder. So what do we do about this imbalance? We have the same problem in the United States. So if we look at enrollment in EDGI by diagnosis, anorexia nervosa is way overrepresented beyond expectations from its population prevalence. And then if we take that one step further and look at participants enrolled by weight, what you see is that 71% of our current participants are at average or lower weight, and only 29% are participants with higher weight. And again, this goes totally in the face of what we know about how weight is distributed in the population. So even though binge eating disorder is the most common eating disorder, anorexia nervosa is overrepresented in EDGI. Why is this happening at every site? This is literally happening in every single site where EDGI is underway. And the only place where they're getting high enrollment of binge eating disorder is actually in the UK GLAD study, which is the study that is actually focused on anorexia and depression. That's where they're catching people with binge eating disorder. But let's look at this a little bit more deeply and talk about what our community feedback has said about why we're not capturing this population. So first off, how do we address the underrepresentation of individuals with larger bodies? And why are sites around the world having more trouble recruiting higher weight individuals? And then what are we doing wrong and how can we correct it? So we've conducted a series of community feedback meetings with people in larger bodies, with African-American individuals, and we're going to be working on meetings with parents of children with ARFID. But why is this BED underrepresentation happening? And here's what our higher weight group feedback said. First off, they said, stop equating binge eating disorder with higher weight. what about all of those people who are living in larger bodies who have restricting eating disorders, such as atypical anorexia nervosa? So we're up against a wall here in the States because we don't have funding, but this sensitivity that there's an equating in the literature and in the popular press of binge eating disorder with obesity and anorexia nervosa with underweight really irritates, grates, and frustrates this group. Second, using their language, they asked us to have more fat folks on our research staff. So their sense is when they go up to the website and they see pictures of who's on the study team, and they don't see anyone who's large, they feel like this is a bunch of thin people or average weight people studying them, and they feel like they're not included in the research. Third, our questionnaires all ask about weight. And we know that this is a sensitive topic for people of any weight who have an eating disorder, but it's especially sensitive to people who have been stigmatized or discriminated against based on their weight. And a lot of them said when they got to that section of the questionnaire, they just skipped out. They're like, I'm not going here, I'm not going to do it. So they asked us to have a pop-up at that point to explain, this is why this information is important and this is why we're asking it. We understand it's uncomfortable, but we need to know this in order to X, Y, and Z. So they felt that at least an overt recognition and apology for asking the questions would make it easier for them to continue on beyond that point. And the last thing is to have a statement, something like, we're trying to move ED research into a more inclusive place. Please join us in making that happen. It's not perfect, but we're trying to move forward. So just in some way, letting them know that we know it's not perfect yet, but we are inching our way toward being more inclusive. I thought the feedback was actually really interesting because they also said the fact that we actually include the DSM language itself is very offensive and fat phobic. So they urged us to not use language that parallels DSM in our recruitment materials. It was very enlightening to participate in these groups and humbling as well. The other thing is we presented them with some of our materials. And on the left, we used this woman to sort of like be broadly representative of larger bodied individuals, we just liked her. And then we created this other, Casey McDermott created this other slide, eating disorders don't have a look. And I was sort of surprised. They did not like this first one at all. They were like, do not put a person's picture in there because no matter what, comparisons start happening. So they'd rather see something like the other picture where it's not necessarily, pointing out a specific individual, a specific size, but just the notion of diversity and that eating disorders do hit everyone. So getting feedback on your materials is so important from the community that you're trying to reach. And then if you look at some of the other ways we're trying to do this, so this is what's happening in EDGI now. So it all started out with the National Institute of Mental Health grant, which is funding collection in the United States, Denmark, New Zealand, and Australia. But again, that's not enough. So Jerome Breen got funds to start EDGI UK. And then I got funds in Sweden to start EDGI Sweden. And EDGI Italy is up and running now. EDGI Mexico is up and running now. Ava Trujillo, whom many of you know, has started EDGI Mexico. Grace Wu got a grant to do EDGI Taiwan, which is just in the final stages of getting its ethical approval. And we're trying to get in many other countries. EDGI Netherlands is still stuck in they're still trying to work with their ethics committee a little bit to get up and running. And EDGI Canada has some ideas about getting started as well. But we're still really low on participation from South and Latin America, Africa, and Asia. And that's really where we need to focus our attention next, in building those relationships, increasing the possibility of people from those countries, starting EDGIs or people participating who live in those countries who have eating disorders. So if you're interested in starting an EDGI in your country, contact us. We're always available. We try to make it super easy. So we've got grant templates that we can use if your country has a mechanism for submitting grants. All the questionnaires are ready to go. They're fully translated into Spanish, into Mandarin now, into Italian. So we've got sort of a mechanism for getting all the questionnaires translated. We've got ethics templates that work both in the States and in Europe. And as far as I'm concerned, in terms of EDGI, the more the merrier. It has just been a joy to help other countries get off the ground and to see us collecting all of this information from across the world so that we can really look at the genetics and environmental contributions to eating disorders across the whole playing field, not just in a small subset of the population. And why are we doing this? So first, we want to understand the shared and the unique biology of anorexia, bulimia, binge eating disorder, and eventually atypical anorexia nervosa and ARFID. We want to destigmatize these illnesses. We've got to erase all these myths that are out there, and the feedback we've been getting from participants is very positive. The questions we're asking, our goals very much resonate with their experience with an eating disorder. We want to be able to predict likely course of illness and tailor treatment accordingly. We're still sort of using this one-size-fits-all approach to eating disorders, and hopefully this genetic and environmental work will help us understand how better to partial treatment out and tailor it for individual needs. Right, so move more toward personalized medicine instead of one size fits all. And think about drug repositioning or development based on genetic results. We still have no medications for any of these illnesses that actually target the underlying biology. And that's striking. Hopefully, as we get more hits in our GWAS, as we start uncovering more genetic pathways that might give us a glimpse into underlying biology, we'll be able to use that work to reposition or develop new pharmaceuticals that aid in recovery. And then create a large participant legacy for research recontact. Over 90% of people say, yes, please, please come back to me in the future if you have additional questions. They are dedicated to this research and to the questions it can answer. And ultimately, of course, to improve outcomes and eliminate mortality. It is still disgraceful that people die from anorexia nervosa every day. And as we've already heard, the pandemic hasn't helped. So our work is not done, and we have a lot of work to do. This is just step one. And finally, thank you. Thanks to the Eating Disorders Working Group of the Psychiatric Genomics Consortium. There are a lot of people, and we're growing every day. To my team at UNC ICED, and to my team at Karolinska, at ICED. And this is all of us. So these are the current active EDGI groups, along with all of our websites. And I can figure out a way to get the slides sort of depictured and circulated to people so that you can look at the different EDGI websites. So follow us on Twitter, follow me on Twitter, and see what's happening in an EDGI near you. Thank you very much.
Thank you very much, Cindy, for such a fantastic presentation. And you already have a fan and someone willing to collaborate with you from Chile. So Carolina Lopez, she is willing to collaborate and to start EDGI in Chile, it seems.
Awesome.
And Chile is such a wonderful country. I have been there.
Ooh, and Argentina. Woohoo! Okay, going south. Chile, so, Argentina, I'm there. It sounds awesome.
Great. And Brazil.
And Brazil. Okay, nice. Send me an email, everybody, please.
Europe.
That is amazing. And I hear Umberto saying possibly Italy as well. So
we enlarge the European arena.
So, exactly. This is Latin American Europe. I love it. It's great.
So thank you very much. Fantastic presentations, Cindy. So we will have, hopefully, any questions, please, you are free to ask. And certainly you might have some questions from Dr. Agnes Ayton and also Suzanne Baker. And now their team colleague, Hope Bargo, has joined us. So welcome, Hope. We missed you at the time.
Yeah,
So
apologies, sorry.
No, it's fine. So any questions from these eminent speakers, please do ask.
I'm very excited by the presentation of Cynthia because it touched many topics that are, for me, from the political view, very, very important that I don't know the answer. For example, speaking about the research to develop, to receive funds, and so to be public, to be read by some readers. It means that or public or die. But is the problem of revision. The revision inside the science is very important because often there isn't honesty, there isn't transparency. You speak about the transparency needed, and we need to enlarge more what happened inside the revision process. Other question for me, imagine when you present the map of the world in Europe, the most important country for the political reason. I understand that it's difficult to say it. I'm very friend of the American, my friends who live in America, but the most important country in Europe is France. France is difficult to get in touch with academy because the background, because not only because they aren't represented in some board, but because they have some barrier against the approach. And so how we can change our approach, very exciting by your words using to define the offensive way where the ESM use fat words against clients practically.
Yeah. No, that's a super interesting question.
Excuse me.
No, go ahead. You can finish. Go ahead, sorry.
No, the last question is, we want to represent the level, the science practically, but we represent in the best, when is the best condition, yours, a representative of 1 billion people, when we live in the world 8 billion people. And so why we can imagine that what we find in between 1 billion people can be the representative for the other 7 billion.
Yeah, no, that is so true. And, and I fight this battle all the time as well, because I get funding from the United States and Sweden. The United States says they don't want to pay for research in all the other countries. All the other countries should do that. And I'm like, the other countries have more basic things that they need to take care of right now, like poverty and hunger and water and pollution, and getting the funds to do that is really challenging. But I think your point about engaging countries like France, we do have France involved with this study, which is wonderful. But I really worry about all of those other big circles that are not represented. We know that there are eating disorders there. And if you think about it, Umberto, everything that we know in terms of environmental risk factors for eating disorders pretty much comes out of European ancestry populations, relatively higher income countries. Their experience, their socioeconomic experience, their life events experience is going to be very different than people in other cultures. And we don't think about that. So these are fundamental questions that we need to really put more effort toward. And that's why, I could have come here today and just given a data presentation, but that doesn't actually address the important points right now. We're at a point in time where we have to address these questions and these obstacles now.
Great. Any other questions from anyone? I had a question, Cindy, if you don't mind, actually. So in 5 years' time, how do you see the world scope of management of eating disorder? We are all, obviously, before you joined in, perhaps, our carers rep and personally me as a clinician and lots of researchers, including you, we are all passionate about getting some solution to our patients and their carers, that how life-changing this illness can be, and sometimes it destroys the family, destroys the career, massive economic and social cultural damage to the families and society at large.
Yep.
With all this genetic study happening, because aim is to find some solution, isn't it? So where do you see the future of treatment side of things in 5 years' time? Difficult question, I do know. No one has
that's
access to
fine.
both.
That's fine. But I'm going to have to extend it to 10 years, I'm afraid, because it's just not going to happen that fast if we look at other disorders. And I think there are going to be stages. Anorexia is clearly ahead of the other eating disorders at this point, unless we happen to find really strong signals for binge eating, which we might, based on the animal literature, we might do this GWAS and say, oh, there actually are pretty strong binge eating signals that give us more information about those underlying biological mechanisms that prompt binge eating. The next step is actually going to be to take that information, dig more deeply, invite our neuroscience colleagues in to start saying, okay, what do these circuits or what do these pathways do, and how can we interrupt them? And that's when we start moving into the pharmacological development area, get some drug companies involved and really start doing this science, because they have a lot more money than we do too. So they can do all sorts of science that, us poor academics don't have the money to do. The other thing, before and while we go in that direction in terms of medication, is to use the polygenic risk scores in order to understand who's at greatest risk, or to figure out who responds best to what kind of treatment. Especially here's an example. I showed you that slide early on from Freeze 2 that had all of the positive genetic correlations with the other psychiatric disorders and all of those negative genetic correlations with metabolic and anthropometric traits. We might find within a larger anorexia sample that there's a little bit of an assortment, that there might be some people who have a stronger psychiatric component to their anorexia and other people who have a really strong metabolic component to their anorexia. And that might actually give us information about what the best way is to intervene with those people. Instead of the same thing for everyone, we might have to really pay attention even more closely to renourishment, maybe to including something that we're learning on the microbiome side for the people who have a more metabolic component, and start to personalize our interventions a little bit more. It's like, yes, food is medicine, but the same food might not be the same medicine for everybody with anorexia nervosa, and this might help us figure that out. And I think that information is probably even going to come before we find those circuits and those pathways that we can target with different medications. A little bit of hope there.
Great. Definitely there is hope, and we are all working for that. I welcome any more questions to Cindy and Dr. Agnes Aiton, Suzanne, and Hope Vargo.
And Hope, we didn't get a chance to hear you talk. I don't know if you heard my talk, but if you had any thoughts about it from your perspective, that would be super welcome.
Yeah, no, apologies for being a bit late. Sorry, I've got a newborn and I just completely didn't realize the time difference. So yes, but no, yeah, I guess from my side, so obviously I work with Agnes and Suzanne and do a lot of campaigning in the UK. And I think the thing from your bit actually that particularly stood out was the point you made about eating disorders not having one particular look. A lot of the work, obviously, in England around eating disorder treatment is all based on a person's BMI, which stops so many people accessing treatment and support. And so obviously here we're working to try and change that, but obviously in the States it's a huge issue as well. And wider issues around funding, things like that, often contribute to that. But I think there is still so much stigma when we're talking about eating disorders kind of more broadly. And I do often hear from the work I do, a lot of young people, but also adults who just don't ever feel deserving enough of that support because they don't have that particular look as well. And I think the other thing actually, which got me thinking about some of the work that we do here, was when you mentioned that people didn't actually like the images with the bodies on, because that's something that I often wonder how we should be depicting eating disorders when we're talking about them, and how we can present them, showing the realities of them, but not glamorizing them and removing bodies. And I don't know if, yeah, we've not cracked it here, I don't think. So it's always good to see what other people are doing.
No, those are really important points. And I'll be completely honest with you. I get really stuck between like the advocacy side of me that doesn't want everything to come down to BMI, and the science part of me that is like, but how and why can some bodies get down to like a BMI of some single digit number, and other people can restrict just as much, but their bodies don't do that. You know, and like biologically, I want to understand those differences, but not offend people at the same time. So it's sort of like a push me, pull you in my head. So we have to figure out. Yeah. But I'm just honest about it. You know, it's like I will just say, I know this is really hard for you, but this is why I ask those questions, because this is what I feel like. If I tell someone in a really large body that they need to gain a lot of weight to be well, that's going to be tough. It's a different approach than someone who, you know, is really low weight. But we just need to keep having these conversations and be honest and be humble, and talk to each other instead of sort of yelling at each other in order to solve these problems.
Yeah, no, I agree. And I think a lot of it's about just not shying away from those difficult conversations and being okay to, kind of bring it all out into the open. And if we don't know, like just saying, actually, I don't know the answer to that, or I don't know how to phrase this, but this is where I'm coming from. Right. And we probably might offend people, but if we don't talk about it, people are going to continue to just suffer in silence on their own.
Agreed.
If I may come in, I mean, one of the difficulties in the UK is people are having to be turned away based on BMI when we have treatments. And I was sort of thinking, well, it's absolutely right that we haven't got a magic wand for treatment, but the existing treatments benefit kind of 50-60% of the patients. And if we had a medication for cancer with that level of success, then that would be available. So there is an interesting kind of political choice, and I would be interested to have your thoughts and everyone else's thoughts on how do we influence that political choice, because it seems to be a problem across the globe. It's not just a UK problem.
No, I agree. And so much of it is correcting perceptions about the illnesses that are wrong. You know, it's like I have colleagues who have started working with me who started in other fields, and they are amazed at the amount of stigma that stands in the way of success of getting people treated for eating disorders. They're like, we don't have this problem in ADHD. We don't have this problem in autism. You are facing a bigger task and a harder task than we are. And definitely folks who are in somatic illnesses, although I don't make the split. And it's so hard to get people to unlearn myths about this illness. And I think it's because there seems to be a continuum between people's own experience with their body. Like, I've gained weight in the past, I've lost weight in the past, and they think that an eating disorder is just an extreme extension of that. They don't realize that it is just absolutely different. It's on a different plane than their own personal experience. Plus just all the history and continued glamorization and misinformation makes it really hard, unless, and I'm going to say this out loud because it's true, unless you find a politician who has a family member or who themselves has had an eating disorder, and then they get it.
You hit the nail on its head, Cindy, because in 2015-16, UK government invested 150 million pounds across 5 years. And that was the change, massive change, actually, turning point for treatment for eating disorder for children and adolescents. And we set up 72 new services across England, which was massive success. Of course, we need more, obviously, but there was no matching funding for adult eating disorder services, unfortunately. So you can imagine that people are falling off the cliff after 18. There is no matching service across there. On the slightly different note, Agnes, you mentioned about treatment in cancer world, and we all know that more recent data will indicate. Thank you, Janet, for joining in, and please join in this passionate debate. You're muted, Janet, by the way. So
no,
I was just saying very quickly that as we all know that from media reports that cancer treatment for breast cancer is massively successful. There are some new drugs which has come up and they are changing the outcome for breast cancer patients and some other types of cancer as well. Similarly, we need that kind of convincing data and figures to work with politicians and policymakers to invest money, because without that is the starting point. We all know that without money, nothing will happen. Thank you.
Janet, were you going to say something?
No, I was just saying I was lurking all the time, but just look, shut off. But what lovely talk, Cindy. You pity you didn't hear mine, because I think we were wonderful bookends. We were saying the same things but about different things. But yes.
Sorry, I was asleep, Janet.
No, that's all right. But if you want my pearl of which I'm rather pleased about in my talk was one thing we've got. I agree with you. We've got all this stigma, but we've got the best relationships with lived experience than any other disorder, I think.
Yeah, that's true.
So, so many disorders have real tensions, and we've just had cooperation, and we need to sing about that.
Yeah, I agree with you. And Ashish, one of the things that you said that I think is actually really important, and it goes back to Agnes's point about 50%-ish effective. We don't have enough research on, and then what do we do for those other 50% for whom our interventions don't work? There is not enough research on that. If I look at, like, for example, what our NIH funds, it's like every clinical trial is a slight variation on the previous theme, CBTX, CBTY, CBTZ, and it's like, who cares? Sorry, I get a little honest sometimes, but it's true. It's like, why don't we just fix what we're doing, disseminate it well, make sure people are getting that intervention, identify the people for whom that intervention doesn't work, and figure out what we need to do with them, because those are the people we really neglect.
Yes, I mean, in the UK, I think it's a very small minority of patients who get access to evidence-based treatment after 18, and it's heartbreaking. So it's very difficult to be a clinician in that situation, and it's also obviously very difficult for patients and families. So I'm getting impatient now, because we had Parliamentary Health Service Ombudsman's report 5 years ago, when they were talking about achieving parity across the age range. And we have evidence that CAMHS eating disorder services have made a difference. So we looked at an audit, and what we found, and I was surprised, only 3% of the patients are transferred to adult services.
3?
Yes, that was just 3%. And there was a bit of a discussion, is that because people are discharging patients to primary care? But even then, you could make out an argument that the investment that they put into CAMHS is actually making a difference. And the adult services are seeing a different patient population with a later onset. And we are still mostly seeing white, underweight patients. So the huge amount of inequality across BMIs, genders, ethnicity. And it's just not okay. So I'm very grateful for Hope and Suzanne campaigning, because again, that's an example of professionals and people with lived experience kind of working together.
I'm also positive about Janet's research, because when you do a research which involves those groups which are underrepresented in our services in terms of accessing the clinical care. So when we reach out to, in terms of a questionnaire or some sort of a study, it educates people that, oh, this is what I have been suffering from, is a disorder actually, and there could be help for that. So it is a kind of vehicle for education as well, our research. And I think that is important point, to not to exclude those kind of population which are important, like you're trying to do, Cindy, and what Janet has done as well. Thank you.
Is the situation better in other countries? I'm curious, like Italy or whoever else is on there.
I'm thinking, no, following your debate now, I'm thinking another time about my question. You know that I was president of the European Federation of the Addiction, and I'm a member of the European Psychopathology, Child Psychology, and that is managed overall by the French colleagues. I reflect on the question, the crucial question is what means evidence. This is the reason because there are barriers between we and French people. And many in Italy too, they are follow of this kind of vision, and reflecting on what others said before, the majority of the clients of the units for treating, specialized treating of eating disorder receive the TAU, the treatment as usual, not the treatment based on the evidence. This is another question that we have to face. We have to reflect more. And it happens everywhere outside our part of the world. This is the crucial barrier that we have to enlighten better. Otherwise, we stay in our world.
Great. So thank you very much, Janet, for your time and fantastic presentation earlier in the afternoon, and all the speakers, Agnes, Suzanne, Hope, Cindy, and Orly and other colleagues who took their time to present today. And I'm so grateful to European Chapter Board, Umberto, our president, and Liz, you are so special in supporting us, and Yael, our Vice President of European Chapter Board, and all the colleagues who joined here today. So thank you, everyone, and hope you have a nice afternoon and enjoy your time, and we'll meet next time again. I'm so grateful to all of you.
Thanks a lot. Thanks a lot. Thanks, Ashish.
Thank you, Cindy, and have a nice afternoon there, Neves and Amelia and everyone.
Thank you.
Oh, see you again. Ciao.
See you.